Welcome to our June Integrated Board meeting. I think everyone is now here, so let's get started. I think it's important just to sort of kick off by stating the obvious. Of course, we have a general election that we're going through. So I think it's probably fair to say that the agenda this month is more focused on some of the operational type issues that we need to discuss, which are still fine during this election period. But as it so happens, quite a lot of the discussions we're having today are for assurance and for update, and decisions that may flow from that will come in subsequent meetings. So just asking you to be sensitive to that, if that's okay. Although the apologies actually say Kate won't be here, I'd like to reach out and say thank you to my colleague here on the right, who at 3 o'clock this morning was still in Manchester, as was Kate, who have beaten their way down the M5.
I can't remember which motor.
So all I can say, you clearly drive faster than Kate because she's still on her way, but Kate will be joining. So Chris will be standing in as acting chief executive until Kate arrives. Thank you, Chris. So we have apologies from Neil, Steve Moore, Ali Borman, and Drew. Molly, is there anybody else you think I've missed? No? No, I think everybody else is. So, declarations of interest. Molly, is there anything that you need to add from what you've seen?
Yes, Chair. In Drew's absence, I just wanted to formally lodge his interest as a councillor at Newquay Town Council, which is not lodged on the paper we've got today. It will be subsequently updated.
Thank you for that. Any other declarations of interest based on the agenda? No? Thank you very much. So let's move to approval of the minutes. First of all, are you happy for me to sign the 9th of May's minutes? Yep. Thank you very much, everyone. Good, we'll sign those later, Molly. Now, in terms of our updates on actions, Molly, if I can turn to you, you and the executive group have been through the actions. Could you give us an update on where we're at, please?
Thank you, Chair. So as you'll see from the document, most of the actions are either ongoing or have been completed. A comprehensive review of the action log has been undertaken. So on that basis, Chair, I'd like to propose that the board accepts the proposal on the actions that are submitted for closure. Thank you.
Okay, are you happy with that, everyone? Yeah, very good. Thank you, Molly. So we'll move on to item 4, which is the health and care vignettes. So just before I hand over to Lucy to do a bit of an introduction here, Lucy, again, 5 fantastic vignettes, but also thank you for doing the summary. So the reason why I'm going to reach out first to Lucy is because the summary has given us, well, I think our approach, I think it's fair to say, was pretty trailblazing in doing this. So over to you to tell us where you think we've got to on the whole package since we started doing this, how it's seen, viewed, what you're doing with it, and then we'll talk about the 5 vignettes. So please do an introduction.
Okay, thank you, John. So since we started the Your Story Shapes Our Future project to deliver these vignettes at our board, we've seen over 70 films produced. I gave an update last November just to showcase what we've done with those first initial set of films, and this paper sets out 34 further films that we've been presented to you as board members. The project itself has developed over time and has had some really nice feedback from across the system and also regionally and nationally. We developed a star framework which shows really just the understanding these aren't just a film that we come to you as board members, they are used extensively in many different ways. So the star framework is outlined in the paper, but really it's about sharing the stories. So we publish them online, we share them in our Cornwall Together, which is an extensive bulletin that goes out to our local residents and MPs and other partners and stakeholders. We share them with our GP and primary care teams across Cornwall and Isles of Scilly. And we've also been sharing them with a lot of professional patient experience and patient engagement networks as well. We've also set out in here what some of the tangible actions have been. So you'll remember the mental health themed films from last month, which has some really good pickup locally on in media. But we have also delivered things like the hearing loss engagement activity with some real tangible changes across our hospitals in response to the first Isaac hearing loss film. We've received extensive feedback from our groups of Core 20+5, which have fed into our Joint Forward plan. We've used films to showcase our winter prevention campaign and our Where is Best campaign. We've had them used by others at their board meetings. We've shared them in minister presentations and award submissions. They really bring to life some of the great work that's happening. So our Pen Hallow film that we created, that was used in a regional collaboration award that's going to be submitted for a national award. So the value of these films has been remarkable, both for the work I do, but also showcasing the great work of our staff across the system, and also how we're embedding the personal experience of our patients in making change for the future.
Thank you. So let's move to any general comments? Sounds rather loud to me, Peter, by the way. Feedback? Okay, Debbie first. Thank you.
Me? Sorry. Thank you, John. So again, great set of films, as John said. There were two that really struck me that I wanted to highlight. The first was the veteran sailing film. Yeah. I found that enormously powerful, but I also thought how poignant to have that so close to D-Day, and how poignant to have that when our thoughts over the last week have actually been with all people that have served, but particularly those on D-Day. So I was very pleased to see that, and I thought it was an incredible story. The second one, it was more what struck me. So I really enjoyed listening to the young people, because we've often said we don't hear the voices of young people enough when we're thinking about services. So I wanted to commend the team for getting the voices of young people to this board in that way. But I was very struck by the word cloud. And at the centre of the word cloud, it said more NHS staff. But then, yes, of course I'd be struck by that. But then the bit that really resonated with me was more friendly people, because absolutely we could do stuff about ensuring that all of our staff are more friendly. That came from somewhere, and it wasn't just one person's experience. So what is that telling us about our services and what more we could do within the resources that we've already got, Chair?
Comment. So there's some great work, Lucy, that you and the team have been doing in terms of getting feedback. When do you think might be an appropriate moment to structure that to come back? Tracy or Lucy?
So we've held our community conversations engagement programme, and it continues every year. This year we are focusing on hearing our younger voices. So the start of that film there is actually a series of work that we'll be doing. We have taken our community conversations findings already to our personal experience, equity and prevention committee. Just wanted to make sure I got that right. And so we're doing an updated thematic analysis that's coming to our next meeting in July. Yeah. So potentially through Nick's paper that comes to board, he can summarise that.
Think about when you actually want that through Nick's committee to come back. That'd be really helpful. Martin, and then Neil.
Yeah, just to, I suppose, 2 points. First of all, it was great to see the summary, and amazing that we've covered so much ground, which I suppose is the benefit of having 4 or 5 each time rather than sort of one patient story. That was brilliant. I think, similarly was touched by the veteran sailing one, and I suppose one thing I took out of it was, I suppose, the dangers of loneliness and isolation, and, brought into mind of the things we, I suppose, are doing to some extent in our community hubs. And the importance of some of that being targeted towards younger and middle-aged people, as well as, we sort of typically characterise the elderly as being, slightly immobile and unable to, or potentially victim to loneliness and isolation. So that certainly made me think about the importance of some of that work that we're doing.
Thank you. Neil?
In the veterans one, when they talked about the one-stop shop approach, and getting as much done and as much people accessed in one day as they did in 3 to 4 months. The phrase, if it works, more people come, was used. We need to be very, very mindful of that we are encouraging and hopefully empowering the voluntary sector to bring in more help. But we don't know. That could be the tip of the iceberg. And what we don't know is how many more people will continue to come. And therefore, if people start to trust certain ways of working, we need to make sure we're supporting them. And one other issue in the X-ray car, you used the word friendly, Debbie. The phrase used by the lady was, I was given kindness and reassurance in the service I had. And I thought that was great. What we need to do is to ensure that, because this is part of channel shift working, care close to home, that as this gets rolled out as a way of working, that we maintain that kind of quality of kindness and reassurance in the ability of people delivering such a service that we want to see for people. And for the young people, there was a myth that was punctured in that, and that was the young lady who said, I don't necessarily always want to text because I'm not sure how private that is. I'm happy to have a phone call. And that really struck me, that we might make an assumption that it's all text and it's all digital. She was talking about someone talking to her.
Very good.
Okay.
Thank you very much.
Just one observation. I thought what struck me about the gentleman who had his hip replaced, when you watch it, the change in his face from before his operation until after, and I realised that he wasn't in chronic pain, and you could see it in his face, and I think hence the importance of continuing with our elective recovery was demonstrated, and that facial expressions really powerfully.
And as you have the floor, and as long as it's in the public domain, as you went to the NHS Confed in Manchester, which is where you've come from, is there something you can talk about that was shared by colleagues there about the channel shift community-based kind of focus?
So in Amanda Pritchard's speech, she highlighted primary care is the bedrock of the NHS. That was a quote. I think you could see lots of people sending that to all of their colleagues as soon as she said that, and she also said, we need to have that focus on system care of delivery, especially in view of the fact that our population is ageing, and highlighting Chris Whitty's report around, particularly in coastal, rural and deprived areas. So that's very pertinent to call on the RCCs.
Community focus.
Absolutely, yeah.
Yeah. Okay, cool. Tracy?
Yeah, I just wanted to say, building on what Debbie said, really, that it's such a privilege, isn't it, for those people like the veteran in the sailing project to be sharing their experiences at the most difficult times in their lives, and therefore we have that moral as well as statutory duty to ensure we're using that learning, which is why I think the recovering paper that Lucy's produced is so important today to demonstrate we are doing that. I'm just wondering how we feed that back to those individuals, because I think it's really important that they understand the impact they're having.
Can you think about that and let us know? So if we can, just before we finish this section, Tan, is there something you want to think about? Because I know that one of Debbie's observations a little while ago, I think it's really pertinent, is theming.
Yeah.
So given some of the things that we'll be talking about as a board later on, you wanted to make some observations?
So Lucy, I thought it would be really good for us to focus on some EDI-themed vignettes, to have one of the next board meetings coming up to be specifically focused around intersectionality, various different cross-cutting themes there around EDI, potentially also in terms of place as well.
And just for those who are in the public domain, you may only really have picked it up from my chair's report, but we will later on in a development session be inviting Roger Klein to actually come and talk to us in a development day about EDI issues, and for that, the broader issues that we have to face of focusing on that, but also areas of bullying, harassment, and our action plans and development, and really get behind that. So I think theming it, Tan, your suggestion is a really good idea, Lucy. Okay, thank you very much, everyone. That's excellent work. So in terms of those recommendations, I think we can, we've watched them, the staff framework using to share. We shouldn't underestimate, this isn't just for us colleagues, this is actually being shared by Lucy's team. So I really hope you recognise that and the great work going on by the team, and to support the development of further vignettes. Okay, so in terms of moving on to the chair's update, I'm going to touch on a couple of points, if I may, that come out of this. As I said a few moments ago, we've got Roger Klein coming later on to lead a development afternoon for us in terms of EDI. He's a very experienced person in this space in terms of academic action. He's been part of the National NHS Workforce Race Equality Standard Group as well. And I think when we get to this section and all the work we do on this, we need to see this as it's all our responsibilities to have shared accountability to do this. So I'm very much looking to the discussion this afternoon and encourage you to be open and add value in terms of what you feel needs to be talked about in that space. So I think that's important to tease out. Board membership is the other thing I want to tease out. So Molly and I, as the company secretary, taken a look at how many people are here, board effectiveness, cost of doing it, and that kind of thing. And therefore, we've decided as part of that to revert back to where we were at the start of the ICB. So we'll be moving back from the attendees that we invited and asking them to attend by exception because it's also their time too that we were consuming. So it'll be more agenda focused. But I can share with you that we are now in a position where Ali Bullman will be reappointed as we get to the 1st of July in her partner role. I'm hoping that Debbie and Steve, the process should be complete for your two reappointments as we get to the end of Friday. So thank you for that. And Andy, where are you? Andy, at this point, I want to say thank you to you. You've been with us on the journey for the last couple of years since we started this. Your tenure continues into the end of June. So on behalf of the board, I'd like to thank you for that. And I just want to continue by saying that the process for appointing the primary care and medical services director will be made by the 57 general practices that we've got here. Thank you to Kerner CIC for helping us in doing that. And that nomination process is in their hands. They will be coming back to us as an ICB with their nominee or nominees, and then hopefully I'll be able to appoint someone by the time we get to the 1st of July. So thank you, Andy, and thank you to Kerner CIC for helping us find your replacement. So I just wanted to tease that out. And the other important process is that we're literally in the midst of now going through sorting candidates and the recruitment process for our company secretary. So I want to tease that out. I think the only other issue, going back to the vignettes, when you look at some of those, there's something about the lived experiences, particularly from children and that kind of thing, that I'm hoping that as we're about to start the recruitment process, Patrick, wherever you are, for the associate non-exec that we approved last time, that once they arrive, we can truly get that lived experience work being brought first and centre to hear from everyone. So that's my update. I've told you that if you need a reminding, we're in the midst of a general election. Is there anything else you would like to add or question on my report? No? Lovely, thank you very much. So we'll move on to the Chief Executive update. Now, as Kate is still somewhere on the inbound, she's lost on the A303, she's going the wrong way, all right, but wherever, yes. Chris, you kindly, as the acting Chief Executive, if you'd be kind enough to walk us through any updates you want to give on that.
I'll take the report as read, and I suppose I know Kate, because she phoned me immediately after visiting St Ern House in Truro with the chaos, how excited she was, and I'm sure she's phoned quite a few other people about it. So just to highlight the work that chaos are doing in the crisis service centre is to be commended, and it fits with that, providing work in the community. And if I can add one additional thing, because it's my opportunity just to thank Nigel Aitchison, who's our Chief Medical Officer for Devon, because he'll be stepping down at the end of the month. And, on a personal level, I'd like to thank him because he's been an immense help, but he's also been an immense help in driving a peninsular approach to how we might look at clinical services. So I just wanted to say, could formally thank Nigel.
Yes, very happy to endorse that. Anything?
Nothing else in the report, but happy to take any questions.
Any questions on the Chief Executive's report? No? Okay, thank you very much. So we'll go on to the committee chairs, partner and participant update. So I'm going to do it in a structured way by looking around the table. So we'll start with the committee chairs. Sanj, anything from your FMP perspective?
Only that the large majority of the report this month is about reset for the new year fiscally. And the key thing I think that we have asked for is around regular CIP delivery reports and also the financial updates to be structured and reset. So the risks have also been reset, but also the monitoring and the format of that is going to be changing. The key thing there is, like with last year, where we flagged early on in the first quarter, where we were off track, that we would want to bring to the board's attention as early as possible if we start to see that also not going in the right direction. I don't want to neglect, and I think we did spend perhaps more time on finance last year than on performance, and this year to get that balance right. So particularly with the new integrated performance report that we're expecting to see, we hope that will give us a better idea of scrutiny, and that the committee reports coming up to the board, and this is something John has asked for across all committees, will be more structured around our strategic priorities, which makes it easier for us to compare the work of the committee against our strategic priorities. So there's a flow through as well in the way we report. That doesn't prevent us reporting outside of those strategic priorities where we see things going well or not going well. So there will be some latitude there, but there's nothing of particular note this early in the year apart from that.
Thank you. Any questions for Sanj? No? Martin?
Thanks. I unfortunately missed the committee this month, but there's a comprehensive report in the pack, and Neil, who was kind enough to chair, can also take any questions if there are any.
Questions for Neil? Go on. Any questions on audit? No? Very good. Neil?
ICA committee, recurring theme emerging through the ICAs currently is integrated neighbourhood teams. Building those as a building block for services and working with local organisations as a system. And one of the things that's been highlighted through the ICAs, which we will pick up as we move forward in the July meeting with the new place directors in post, is the theme of how we enact channel shift and how the yearly planning cycle does and innovations. Just wanted to raise the fact that we need to be grateful to the departing managing directors, who include Andy and Rob White, in their roles of taking forward over the last 2 to 3 years the integrated care area work from where we were to where we are now in terms of building neighbourhood teams and working in a delivered, systematic way to provide efficiency of working with the voluntary sector. They need to be greatly thanked in what they've done, and thank you for that. That's the ICA. Did you want me to talk about quality?
Please.
Yeah, sorry, I'll just make sure I'm saying all the right things. I'd like you to take this as read, but in particular for the board information, in case this is something that begins to get flagged up, the issue of new ways of managing diabetic care involving hybrid closed loops will need, and we were very keen on this, through the new ways of working around diabetes, to ensure that the rollout of this takes note of health inequity in terms of prioritising. ICB annual complaints report and Freedom of Information annual report were noted and welcomed by the committee, and they are there in detail for you to look at.
Thank you. Steve, you want to add something?
Yes, just a question, if it's okay, Neil, on the ICA committee paper, really helpful. I wasn't aware that we'd confirmed until I saw the paper £750,000 of resource to the 3 ICAs, so helpful to be cited on that. If I've understood it, that is for channel shift. And I just wonder if we could ask for a kind of a brief update as to what we expect that to deliver, and whether that's something we'll be able to kind of come back to in future reports, if that's possible.
We will be able to do that. That money is now welcomed because the plans and priorities around that were already expected and in place for the ICAs, but we can bring that back to future board meeting.
Would you like to add anything? That's your... Very happy to do that. Yeah, very good. And as a direction of travel, I think it's important as part of our, and I know you're the vanguard of doing this, saying this, Neil, is it's an expectation to move towards more funding towards that channel shift. And therefore, as we start to get to the agenda items later in terms of planning for 25-26, we need to think about quite what's working at community level, and how we make that channel shift even greater for next year. Thank you, Neil. So to try and keep the theme going from quality, let's move to Nick, because Nick, if you kick off with the SEEK committee, the Systems Quality Committee, that'd be great.
Thank you, Chair. So systems quality, obviously it hasn't met since last time, but lots of work going on in the background. I want to thank both the three organisations, for Chief Medical Officers and Chief Nursing Officer from RCHC around setting agenda for next time round, which is really important. That's been done in a very collaborative way. From an ICB point of view, I need to thank Chris because he's been definitely helping me with that. The other thing as well is I've also reached out to quality chairs. So quality chairs are getting together as well to discuss that.
RCHT and CFT.
And RCHT, CFT and ICB. And that's coming on the 21st, I think, so that we've also going to get that in place. What we found is meeting, again, I think was received, and I welcomed the feedback very gratefully last time. I think what we've been concentrating between now and then is making sure system and process and feedback is secure moving forward. So now what we've got is we've got a more rigorous process for debrief afterwards, agenda setting, minute sharing, those practical nuts and bolts things to make the committee as good as it can be. Chair, and that's the important bit moving forward. Again, all I've had from all organisations is collaboration and confidence that it's the right thing to do, and we'll keep working in that vein, Chair.
Move on to your other committee, that'd be great. So if you can move on to the Equity and Prevention Committee.
Again, with this one, we've had a change of executive, so I need to thank both Tracy and Lucy in that space for helping with people experience Equity and Prevention Committee. We were going to step down the committee, but what we actually did was had a really useful meeting around some of the a fantastic report that Lucy had put together around lots of perspectives around CQC and assessment framework. What's coming next, which is really important, is an assessment framework, so that it doesn't matter about the conditions, that we can actually apply a standardised assessment framework to a lot of this work. And then that, to your request, then, Chair, will align with the strategic priorities on future reporting. So, again, we've been working on the process of that in the background, and happy to take questions, Chair.
Thank you. Any questions for Nick? No? Tom?
PCCC, minimally, dental strategy is developing, and that'll be coming back again to the next meeting. Nothing specific else to note there. Workforce, good news. The application that we submitted for Workwell has been successful, and Patrick and the team are developing that. There will be a £2.2 million investment into helping us retain staff who are currently off sick, or helping people who have some long-term conditions to come back into the workforce. So the team are working on that across the whole system now, so that's really good news. And just in terms of an update, we are anticipating more discussion at our next Workforce Committee on the 27th of June about staff experience.
Mary.
Thank you. I really welcome that news about the money, and I know when we talked about this before, we were talking about how that work was going to link through back into this committee in terms of governance and so on. Do you think you could say a little bit more about that? Perhaps Patrick could do the detail for us.
Yeah, by all means. So I think the last board mention of that, we identified that the Workforce Committee would have the overview, and the Chair's report is providing the update on the first conversation we had. We had a good hour, very engaged session at the last Workforce Committee. In terms of programme governance when it comes to delivery, we're working that up as part of the service design. Programme goes live in October, and the work that's happening across the system, as Tom mentioned, is to design what that service will look like, and then what the governance would be of overseeing that service operates effectively. So still in design.
I could just briefly come back, that sounds really great, and I think it might help us as a model for how we monitor the outcomes of other processes and other funding, such as the one we've just been talking to.
One of the principles I just want to emphasise, and it was in our bid, is that We'll have formal governance through the partner organisations, ICB, ICP, Council. We want to make sure there's a user experience governance forum that oversees the day-to-day operation of how the service is operating. That's the bit that we're really designing. I'm less worried about the formal governance. I think we've got the structures for that. It's the user experience, participant experience that's going to be.
Thank you.
Thanks.
Yeah.
In terms of outcomes for people from that work well process, are they more personalised care approach, as in outcome for individuals, or are they a numbers-based number of people back to work type approach? That's a really pertinent question relating to the design of the service. In terms of the DWP DHSE metric that we will be receiving money on, the kind of formal measures, that is about participants being on an action plan that helps them address the health barriers that might be preventing them into work. It is worth saying that that isn't about tracking their onward journey and the sustainability of that, but that's something that we're working on within the programme to be the proper measure that we really want to ensure is covered. And then other debates around what are the actions and support that help people on their journey to stay in work or to access work. Again, those metrics are being developed within the service design. So Neil, just very struck by the turn to starboard statement that the difference that was made to that person was that they didn't feel they were alone.
Mm-hmm.
So, Patrick, having personally worked in this space with DWP over a number of years, there's something about winning contracts, but there's also something about re-winning contracts. You don't have to do the minimum, so we can choose to go further than the minimum. So Neil, this particular contract for me, contractually, as a grant, is actually about interventions. It's more aimed at people with disability and mental health issues that keep them away from work. But just doing interventions and not ending up in work, we need to go further than the minimum. So one of the challenges that Patrick will actually have as part of that team is, I know the contractual grant criteria, but how much further can we go? You know, we're in some ways a not-for-profit, not a for-profit organisation. Therefore, there's something about the purpose behind here, not just the grant. Emma?
Let's come back on that first, Patrick.
No other than just to confirm that's exactly the ambition we've set
I know.
ourselves
I just wanted to pick up on Neil's point. Thank you,
I guess in
Patrick.
terms of feeding into the service design, making sure that we close that loop, and where we're identifying thematic areas of challenge or barriers or concern within either sectors or within organisations, that we actually are able to effect change. So it's not just that we're supporting the individuals, that we're actually seeking to shift what may need to change in terms of culture, support, processes within our organisations as well. And I know that's a bigger piece.
Yep. Okay. Patrick?
I will just take the opportunity to highlight that one of the first actions we're doing with the 2-year funding is to recruit a dedicated work and health lead into our system. That closed midnight last night. So we're moving ahead with the shortlisting and appointment arrangements for that role.
Okay. One of the joys of working in Cornwall is you're never quite sure what the weather's going to be. So last month it was too hot. The previous month it was actually snowing, if you recall. And today it's full on wind and rain. So all things to all people, depending on when you turn up.
I like the air, but I can't
Once
hear
the-
anything.
Once at a cricket match between England and Australia, I remember somebody actually as an Australian saying, I can't stand the weather here, to which point the Englishman turned around and said, wait 50 minutes, it'll be different, which just sort of struck me. Okay. Okay, thank you so much. Anything else, Tan?
No, that's it.
Done. I think I've done everybody on that. So let's move to partners. Now, Ali is not here, so we'll take hers as read. There's no one else from the council to say that. But if you wanted to, Mary?
Just to follow up on what I said last time, that the situation is getting fairly critical in terms of the loss of funded nursing care beds in the care sector,
Right.
and the increasing complexity in residential homes. And I sent an email to Ali and to Rachel Rotherhove yesterday, which I think they forwarded to you, Chris. Yeah, so I think the risk register needs to factor that in at some point, with somebody who's better at number crunching than we have access to any data for. There is no lack of capacity in care homes in Cornwall at the moment, which is amazing and good news to hear, except that it compromises viability for some of the homes, which, as we go into winter, might lead to a little bit of more of a crisis in care.
Can I just be really clear? You're saying there is no lack of capacity for care homes
At the moment, everybody's telling us, no, we're told there's no beds, but actually there's a lot of beds. They may not be in the right places.
Okay.
They might not be looking after the right category of care, but that needs somebody to stand back, look at it, look at what's needed, support us to make different providers to make the changes that are needed. There's a lot of work doing the market development strategy, which is looking at new builds, but that's going forward. We're going to end up with a gap in the middle when some providers look at this and think this just isn't worth it. I'm going to retire and sell it for a building plot.
I know.
And
Okay.
I do think that needs to be.
Very good. So, Susan, maybe particularly for the winter plan that you're already probably starting on?
Yeah, and I think it's a piece of work that needs to happen regardless of winter.
Yeah, I get
but take the point that we do need to do some safeguarding work.
I thought, do you think?
So if I pick that up through our relationship managers that are now in place, and with our local authority.
It's a good call. It'll be different by each location. So thank you, Mary, for raising that. Steve?
Just build on that. So thank you, Mary. I'd certainly support that being considered by the board from a risk perspective. I don't know if this is related to that, but I am mindful we've seen a significant deterioration in the number of no criteria to reside patients within CFT and RCHT, and to a lesser extent within UHP as well. I know ICB executive colleagues are progressing that, and really grateful Susan Criswell-Leighton's support and kind of direction with regards to that. But just for us to be aware that that has been a significant deterioration, and I think all organisations are now significantly worse than the plan that we'd set and agreed from a no criteria to reside perspective, and particularly, well, that's actually across all P1, P2 and P3 patients.
Margaret?
As we're looking at it, can we make sure we're looking at broadly at all of the patient groups? Because we have big issues in mental health with places, so, and dementia care. So could you, it's not just for elderly, it's people.
Yeah, and we've had this conversation at board before. So we do need to be talking to our nursing home colleagues, because we know that the market for placement for dementia particularly has deteriorated, and I think regional colleagues have also given us a push to think about how we do it differently, and we don't rely consistently on nursing home placements for people with dementias. But it's a fair point, Margaret, and obviously we'd be picking up the whole spectrum within nursing home placements.
That's probably outside of your remit, but it is the remit of the council, and that's the interface between the two. That
Absolutely.
You'll pick that up with Ali? Yeah, thank you. Debbie?
Yeah, so following on from Margaret, so within a subset of delays in community hospitals and in our mental health beds, we've got people who are waiting for housing solutions, and that number is growing. So it's not right for people who are waiting for housing to be in hospital beds, because those solutions often take a very long time to come. And I know strategically the local authority is really working on that, but if we could pick up some of the challenges within some of these subgroups, I think it would really help flow.
Okay, thank you. Thank you. Okay, Mary.
And I think there are some providers that would be willing to consider converting some of the perhaps more tired stock into some sort of supported living arrangements, if that was supported in the discussions.
Susan, you're going to take this away.
Yeah, no, absolutely.
Ali's not here, so I'm just conscious of Ali not being here. So let's move on to... Is it really quick?
I was just going to make a suggestion that maybe we could have an update on this at the ICB Partnership Board ahead of the next board meeting.
Yep, very good. Well said. Debbie.
Thank you. So I carried on the research theme this month. So I know the learning disabilities and research theme was really well received last month. So we are becoming a research active organisation in CFT, and it's part of our strategy, but it's also part of what improves care for patients, because at the end of the day, it's yet another dimension of improvement. So I'm really grateful to Simon Van Jones for showcasing his research, or the research that he leads with a team in older adults, but especially dementia. And there are a number of themes I just wanted to highlight very quickly. The one is, look at the recovery since COVID. So we often talk about services that need to recover from COVID in terms of direct care, but actually research has needed to recover since COVID as well. Through this approach, we are now, as an organisation, we've now got 6 commercial trials in CFT, which are income generating and bringing funding into Cornwall and the Isles of Scilly. And we're working closely with RCHT on that. But we had a World Cafe event last week with our board, and what was absolutely evident was each of the studies brought service users with them, and we are embedding co-design and service user engagement and involvement at every step of the way in research, as good research practice would highlight. But we also heard that Cornwall and the Isles of Scilly is becoming an attractive place to commercial trial sponsors, which was news to me, because I thought, it must be harder, particularly because my last place of employment was Oxford. But apparently, particularly with some of these groups like older adults or carers research or the learning disability research, we've got much more settled and stabled population. So therefore, there's an appetite from local people to participate. They can see the benefits. And when people sign up to trials, our retention rate is better. So actually, Cornwall is, and it's RCHT is seeing something similar. Our recruitment and then retention rate in trials has actually been better than some of our other regions. And also, there's an interest in what can be the difference with coastal and rural populations and urban-centric populations. So, of course, there are challenges conducting research in areas like ours, but there are massive opportunities that Margaret and I felt we would really want to highlight and illuminate here today, because it's often not heard. So thank you for giving me the opportunity to showcase this today, Chair.
Thank you very much indeed. Excellent. Any questions? No? Okay, Steve. Thank you, David. Steve.
Thank you. Just to welcome and acknowledge that report from Debbie is really helpful, and the research ambition from CFT, I think, is really clear to see. Just to build on that, we're intending to bring this to a future board meeting, but one of the exciting developments underway is bidding for a NIHR Commercial Research Delivery Centre to be here in Cornwall, which would absolutely complement the work that Debbie has just described and be transformational, I think, for our intent to grow and develop research further. So if I'll include that in a future NHS provider partner member report as that opportunity progresses. In terms of the report that's provided, I've got nothing to add to what's in the report, but two things I did want to draw to board's attention that have progressed since the papers were issued. The first one is we'll probably all be aware that we've received a notification from BMA of Junior Doctor Industrial Action. That's scheduled 27th of June to the 2nd of July. All NHS provider organisations are now well practised in mitigating as best we can the impacts of industrial action. But in each and every industrial action, we have experienced impacts with regard to the services that are provided. So that planning is underway. Should particularly note part of that, John, that all parts of the NHS have been required to submit their operational plans on the basis of no industrial action, and that includes the basis for the plan that we as an organisation and as a system have submitted. We do though now know, unless that action is stood down, there will be industrial action. which will have performance implications and financial implications, and it's not yet clear how those things would be considered. We haven't yet had confirmation from NHS England whether mechanisms that we used in previous industrial actions will apply in this industrial action. So that was the first thing. And the second thing is to make colleagues aware that we experienced an IT outage this week. So on Tuesday of this week, RCHT experienced a network access outage that impacted the vast majority of our clinical systems. It also impacted a number of systems that support Cornwall Partnerships NHS Foundation Trust and some aspects of the wider health system. Immediate business continuity mechanisms were put in place, a really very, very rapid and positive response from our Cornwall IT services and our operational colleagues, and Calvin was leading the SITS response. We were able to re-enable access to all systems by mid-morning of the following day. Full access, network access was restored partway through the day of the industrial action. So all of our systems have now been re-enabled. There was some impact on the day of the industrial action, John, so we did need to cancel or postpone a number of outpatient appointments and a small number of surgeries. And our teams are already reaching out to those patients to enable those outpatient appointments or cases to be rebooked. Some of them already have, but we'll be continuing that process as rapidly as we can. So I just wanted to take the opportunity to update board members about that.
Very much. Any questions? Emma?
It was maybe for Steve and Debbie actually about the research piece, because we've also got the health determinants research collaborative work happening led by Public Health in the Council. So I wonder if through somebody like Andrew, we could, just so we've got visibility over all of the different types of research, because I suspect there's lots of links between all of them. We might want to think about that for the future.
Thank you. And while you mention the research thing, I was going to add, we've got on the agenda for September an update on research innovation strategy. That'll probably involve John Sindel. And Kate and I and John Sindel have been speaking over the last few months, because after what used to be called Horizon 2020, which is research innovation funding, was stopped because of the European issue. It's back again under the badge of Horizon Europe. And sometimes we forget the massive amount of funding there is available to pump into research innovation if you can put together a cogent bid, an argument, and there are specialist people aimed at doing that. So I think one of the things that we should ask John Sindel, if it's all right with you, is how is he going to come back and inform his board how we plan to tap into that to support the work that Debbie, you and Steve, you've mentioned. Is that okay with you?
I think it'd be really useful to do that. Yeah. And to kind of align that with the work that's just been described, the ability of all partners to come together and perhaps update all of us as a board as to that work, and then to be challenging John on how do we expand and take that forward, I think would be a great set of.
So on behalf of Kate, Tracy, would you mind taking that away and making sure that John Sindel's clear? It's not just what he's doing, it's just the wider funding from Horizon Europe as well. That would be great. Okay, thank you very much. Let's move on. Andy, anything that you wanted to add?
So, verbal report, but I would direct you toward Tan's report from Primary Care Commissioning Committee as a highlight of what's gone on in general practice. But just to use some precision of language around the industrial action, I'll quote from the British Medical Association. Starting on Monday, the 17th of June to the 29th of July, the BMA will be holding a non-statutory ballot of GP contractors to undertake collective action, not industrial action.
Okay.
So just for the minutes.
Thank you very much. Thank you. Okay, colleagues, let's move on. So unless there's anything by exception, we're running slightly late now.
What's the difference? Sorry, I'm just...
So industrial action is for employees who are a member of, right, okay. And collective action is for independent contractors. We're just being clear on the language.
Thank you, Steve.
Apologies, John. It was relating to the Devon ICB report, and I know we don't have colleagues from Devon ICB here, but I am mindful. There was an announcement just a couple of days ago about the chair of the Devon ICB resigning, and I understand that the comments that have been attributed to that are with regard to concerns in signing off the operational plan for this year. And my question was going to be of Steve, is it possible to have something back to our ICB board that just sets out whether there are any additional areas of risk or concern from a corneal analysis study patient perspective, so that we can support and engage in any ways to mitigate that, or if there are no further concerns, to have that assurance from our Devon ICB colleagues.
Thank you. Before I bring in Emma, I'll respond to that. So I support that, and I've already reached out to Kevin Alford, who is the interim chair that's immediately taken up the role, just to get clarity on what their perspective is and our perspective on that. So I've asked my PA to organise that urgently. Thank you. Emma.
Just quickly, thank you, Chair, to come back on what Dr. Sant was saying about the collective and the industrial action. Just for absolute clarity, so it is less about the contractor and sessional sort of aspect. Collective action is the non-breach of contract action that can be taken. So that could be taken at any point and doesn't breach a contract, whereas industrial action is very much the trade union territory and requires further formal balloting. So I hope that makes sense.
Lovely. Okay, thank you for clarifying it. Okay, colleagues, thank you for that. Let's move on. So we're moving on to the integrated performance report. Now, Susan, Patrick and Simon, there's a lot in here. I'm sensitive to keeping this to just straight operational issues at this delicate moment in the general election window. I'm pleased to see that we're actually starting to get some HR information as we're starting to sort of go through this process, but also the fact that soon this should be the end of the old format, and I'd like you particularly to share some of the work that we're considering working on going forward to actually raise the bar on our IPR. So maybe, Susan, if you could kick off, and then just very briefly we'll touch on your dynamic, then we'll go to Patrick, and then we'll go to Simon.
Thank you, Chair. We, as you know from previous discussions here at Board, we have been looking at changing the format of the IPR. I think it's fair to say that NHS England region have encountered, talking to other ICBs, similar issues that we have with the IPR, whether or not there's too much duplication of provider IPRs and how much we report as a system IPR. So there is a template that we will be getting from NHS England in the not too distant future. I think, so what I would like to say, however, is we've continued to iterate the IPR based on the comments that you fed back to us. So trying to get some of those trend lines in to see where we were the month before to where we're going. What we need to do is put a little bit more narrative in that balances out some of the metrics that we've got in there, so that gives an idea of what we're doing, where we're seeing unwarranted variation, where we're seeing any of our performance slipping. So we will see that emerging as we go through. I have taken on board the last set of comments we had about an easier read, which is quite a challenge actually with an IPR, trying to make it an easy read. However, it's a challenge that we will pick up. And in line with the IPR being a lot more focused on our operational plan and our metrics constitutional, as well as the single oversight framework, we are also doing the same with our system coordination centre. So that's that system meeting we have every morning at 9 o'clock. We're very focused on those metrics so that we are getting much better at that one narrative across the system, and where our partner organisations don't feel that we're reporting anything different, which can cause confusion, but also can cause a lack of confidence sometimes in the data that we report. So I'll take the IPR as read, knowing that it's a huge document, so thank you for reading it. But we're really clear that this is the March-April position. This is the validated data. Some of you will have seen more up-to-date data, but again, it's not been validated. So I just report on what we accept as the system. And it's been good news through March and April. We've seen some of our metrics, particularly around the single oversight framework, improve. However, the piece of work that we continue to do through our 6 priorities as an ICB is to try and find a consistency so we don't see that variation. We know that the single oversight framework is very much targeted towards urgent emergency care, elective cancer care, mental health and primary care. However, there are other elements that we are still measuring outside of that, which is in line with our constitutional framework, but also
are priorities as well. So trying to get the right mix within the IPR is tricky. However, what I would like to say is our category 2 mean time for ambulance has improved into April. We are seeing some inconsistencies. We've had a very busy June, it's fair to say, and I think the attendances at ED have been above where we thought that they would be. So there is still more work to do, but however, we are creating a much safer environment for our population in terms of ambulance response rates. Our overall 4-hour performance across our ED departments, our MIUs and our urgent treatment centres are improving, and we've got the NHS emergency care intensive support team working collaboratively with RCHT to try and improve that type 1 performance, so that's that ED performance. So there's a lot of work, and we are reporting that through our tier 1 meetings with NHS England. Our referral to treatment is improving, and we've seen a reduction in the overall waiting list since April last year of nearly 13,000 patients. So a huge amount of work that's going into that. And we are sticking to our trajectories for both our 65 and 78-week position. As it stands at the moment, we have a position of 11 patients at the end of June for the 78 weeks. However, RCHT and the ICB working very hard to ensure that we get to that 0. However, we do need to take into account patient choice and also our tertiary partners as well, who have their own challenges with waiting lists. 65 weeks, we are still on track, and we've put our submission in for 0, and we are using our independent sector. It's fair to say that a lot of the specialties within our RCHT are hitting their targets on 65 weeks. I think where we've seen, and we've talked about this a lot before, where we're seeing some of those delays, it's around trauma and orthopaedics. However, we are working with RCHT and offering a lot of patients, and they're accepting the ability to go out of county for their treatment to ensure that we get that backlog down. And that's really important for our overall safety of our patients in ensuring that the deterioration in joints particularly are not getting any worse. It's great news in terms of our diagnostics. We've seen 6 consecutive months of improvement, and I think we are now ranked 2nd ICB in the Southwest, and not that far behind where we were pre-COVID in terms of our diagnostics. And we know that diagnostics is a linchpin overall for our planned care. We've now got the investment that we've put into our community diagnostics starting to really see an improvement, and we will continue to see that as we go through the rest of the year. Cancer faster diagnostics has also, it's seen a marginal decline in the month to 80%. However, we have got an ambition, as we have put into the operating plan, to improve that, and that is working. And the data and the sensitivity of the data tells us where we've got those issues, and that collaboration with RCHT helps us improve on those areas. I think with the other piece of work, and we know that we've been under huge pressure with mental health, the demand has been up, and we know that our out of area placements have risen. We've set a trajectory to bring that those out of area placements down by the end of the year. However, there's more work to do on that to ensure that we are repatriating our people back into our county. And I can't not mention the work that we're doing with Plymouth as well. We know that our no criteria to reside in Plymouth has been high, so the work that we're doing with Plymouth, but also around our elective care. And we'll talk later about our elective surgical hub, which comes online later in the year. I'm happy to leave it there, Chair, and take any questions.
Thank you. Debbie.
Thank you, Chair. I just wanted to ask that when we're reporting on out-of-area placements, that we also report in the same breath on no criteria to reside and delayed discharges, because we've actually got more delayed discharges in mental health than we've got out-of-area placements. So Susan's absolutely right. The demand for mental health is extraordinary at the moment. So we had a slight respite where we reduced our pressure status to Opal 3. We are back in Opal 4. And we have our equivalent of an ambulance queue every morning for people that are requiring admission under the Mental Health Act. So that does put pressure on community mental health teams who are holding people in the community. It puts pressure on emergency services and on the emergency departments. Now, the team are doing a phenomenal job on that. but delayed transfers of care has got to be part of the approach to an out-of-area placement trajectory. The two have to run in tandem, please.
Yeah, just some reflections from me, which on some of the things that we're thinking about in HC. I chair the weekly Tier 1 meetings with the system. So firstly, just really how everybody works together is definitely worth kind of acknowledging, because it's a really good piece of partnership and joint working in very difficult circumstances. There was a call this morning of our chief execs from across the region, and Steve will have been on that call, where there was a challenge set by the chief exec of SWAST about consistency across every single organisation in the Southwest, because the Southwest nationally is still an outlier, despite comparable populations, geographies that are mirrored elsewhere in the country. We still seem to have this issue around ambulance handovers, and gives us a pressure. So quite rightly, I think we were all challenged as chief executives and leaders to say, if it's done somewhere and it works, why don't we do it everywhere? So I think the view was that at some point there should be a kind of wider system discussion about that, to really just go back and say, if we could do it, could we do it? Or if we're not doing it? And I think was a fair challenge in the circumstance.
So what will happen as a result of that?
So John's followed up with John's followed.
Peter, we're getting some feedback on Kate's mic.
I've turned it all on.
Right.
John Martin, I've turned everything off. Everything's off.
Okay. That's right, isn't it?
Yeah. Is that okay?
Yeah.
So John Martin sent an email out after the meeting this morning to basically say, would one system or two systems offer to pilot max holds? He said from his previous experience, it means that everybody has to collaborate that much more, but that we make a commitment to capping the time that any one person sits in an ambulance. So he's asking us to consider whether we would put our hands up for that. So I think we need to take it away and think about it.
Thank you. Martin? Oh, sorry, did you?
Yeah, no, unless Martin was getting into the UEC discussion, my only other comment was, I think we'll come to that. There's a huge opportunity for the system around elective work. And I would encourage the board to think about how it wants to take a strategic view as much as a tactical view around elective care. So I think we'll probably touch on that later. And the other thing about cancer is look at the screening rates in the system. We're seeing quite significant variation, and obviously cancer screening and early detection. Our public health budgets, of which I am commissioner, are under huge pressure. And I would be loath to lose sight of them, because actually if we can get further upstream, then we can get cancer at an early stage. And then I would echo Deb's point about mental health, particularly around young people, where there is massive pressure, and particularly we're under-resourced at the moment in terms of capacity. I've closed capacity at Riverside, and that is causing problems. So we mustn't lose sight of that as well. Thanks.
We also know we're going into the summer holidays, that pressure.
Indeed, huge.
On beds will get worse.
So we will pick up elective later.
And the only final comment from me was keep the pressure that we saw in month 12 around workforce towards the end of the year needs to be sustained, and month 1 has slipped a bit, and I'm sure that the system is cited on that, but the pressure on terms of the workforce controls need to be continuing from where you were at the end of the year.
We'll come to that, that's for sure. Martin, did you want to add something?
Yeah, two quick points. First one was on, it was great to see on orthopaedics, and I think it was hips, some more super clinics, which has, driven some more activity through more rapidly. The thing around MSK question mark, was it quite working, was interesting. I just wanted to know, am I characterising that right, that some people are on the waiting list who probably shouldn't have been, maybe should have been filtered out earlier. So is that the case, and are we going to sort that out? Second question was more on the, I suppose reflecting it probably on the non-elective side particularly. It sometimes feels that we are doing a bit of whack-a-mole sort of thing. We sort out one problem out while something's coming up somewhere else, and it's, how do you make sure that we are, I suppose, keeping our key areas all working, all the plates spinning at the same time? And I know it's difficult when we've got staffing controls, but it sometimes seems that some areas we sort of lapse a bit, perhaps through sickness, less resilience. So, how do you make those key things really resilient so they're all working to the hours they're supposed to be working, I suppose?
So I think to take your last point first, through the SCC now, through the System Coordination Centre in the morning, we're very cognisant of that, in that we don't necessarily have the resilience in the right places. We know that particularly out of hours is when RCHT are really pushed in terms of demand. So the work that we're doing around the 24/7 is really important, that we land the right resources in the right place, because again, it's not an open-ended budget. We have to make sure that those resources are absolutely where they need to be. The other thing, Matt, is I asked, because I chaired the SCC twice this week, is about the efficiency of the resources that we've got in place. So we've put a lot of money into community resource. We need to make sure that it is working as efficiently as possible. And on that point, I'd just like to say that the frailty same-day emergency care that we've got in Bodmin, and we're putting one down into West Cornwall, we now need to think about how we divert some of those people that would normally go to ED away from ED, because we know from the work that's been done consistently through Newton Europe, KPMG, we know that some of the biggest demand comes from people that have frailty, and also end of life is the other area. So I think we need to think differently about people, a little bit like we've streamed minors away from ED. We need to do the same with frailty, but not ration services. That's not what this is about. People who need to be at the ED department will be there. But the infrastructure now in the community is such that we've got community diagnostic hubs, we've got urgent treatment centres, and we've got community assessment and treatment beds. So we need to divert some of that activity away from ED.
So just before I'm going to bring in Neil, Kate, Nick and Kate, but before I do, Rachel, just so you're cited, something that Sam's referred to earlier on, I'm in the process of meeting with each of the non-execs with Molly, our company secretary. There's something about, I think all the committees are doing a fab job. There's something about raising the bar now in terms of actually scrutinising our top objectives. And although some of our committees are getting through a volume of work, now is the time, I suspect, just to sort of pause, take a look at some of the things that we're looking at, and actually getting each of the committees to actually just focus on our strategic objectives and really unpack that. So that work, everyone, is about to start to roll forward. So in the next order, it was Neil.
So the things you were mentioning, Susan, the SDEC, the community work, for me, that's the balance that we need to shift over in order to make the changes that we believe are the right thing for patients. In time, I would hope, and we did see this in this report today about the SDEC, that there will be, although we must remember that measurement of outcomes in this area is a collaborative one. It's not always one thing that's affected things. But I think probably there should be more in the integrated performance report about the measures we're taking in the community as there are in the front door.
Thank you. Nick?
Yeah, thank you, Chair. So welcome the discussion on elective later. So two really simple questions. Steve referred to the industrial action. So have we got any idea of how that would affect some of that? Because obviously that will push it back. And when we talked about out of areas, does that have it's the right thing to do? We've seen that in the vignettes, but does that have an additional cost implication to us as a system? Two questions.
What do you want to do on that?
So so it's GP industrial action, yeah?
No, I think Nick's referring to the junior doctors industrial action, 27th of June to the 2nd of July. So I'm happy to answer that initially, if that would be helpful. That places at risk 4 days of elective operating, the Thursday, Friday, Saturday and the Monday. So that would be about 15% of our elective capacity in a typical month. We have been able to mitigate that in previous industrial actions to an extent, but as I mentioned before, every industrial action has of that nature has reduced elective activity throughput, including in orthopaedics. So that is a material risk, I think, to the 65-week delivery that we're required to achieve during September. So working hard on further options to mitigate that, but currently that would be a risk of in the region of 4 days. There is the potential for it to impact on a 5th day, on the day the strike finishes, depending on the legacy impact of the consultant deployment during those previous strike days as well.
Yeah, no, thank you for that. And I think it's just an overall positive IPR, but it's right to recognise that.
Thank you very much. Kate?
There was a second. Was there a second?
Yeah, well, it was we saw in the vignettes about the difference it made to our people of going out of area, but does that have an additional cost, was the question to us as a system.
So in terms of outsourcing, when we're sending people out of Cornwall, And most of our outsourcing is done at tariff, but it costs us a little bit more to help people get there and for it to be a reasonably pleasant experience. Yeah, thank you.
Thank you, Kate.
So the point I wanted to pick up was around the infrastructure in the community and the tipping point that I think Neil was alluding to. So almost financially, we're at the worst of all positions. Of course, we've both bought both sets of service, and we're at the point where we are going to have to take that leap of faith of moving the pathway so that when West Cornwall Hospital opens at the end of June, beginning of July for frailty services, that we are reshaping the way that those pathways go. And the experience that we've got so far from the outcomes from Bodmin is it's better for people. So it's probably an effort that's worth all of us making. And then that should start to see the money dropping out as we've reshaped the pathway and we've got people in the right part of our system. So I just think it's useful to hold the two things together.
So what we're going to do is we're going to take Sanj and then we're going to move on because we're starting to slip behind. Sanj?
Just 2 points. One on SDEC and diverting people from RCHT. Is it not the case, or can it not be done, that they don't go to RCHT in the first place?
Yes.
Right.
Yes.
Okay, that's still the case. And then secondly is, given the out of hours demand on RCHT, is SDEC in a position to provide that 24/7 cover out of hours? You know, as in when it's the worst timing for RCHT, do we have community resources out of hours to pick it up, or is it during the working day?
So we don't have that consistently at the moment, Sanj. That's the work that we're doing around one of our priorities for the ICB around 24/7. But we need to be clear about that modelling of how much of the demand is at what times. So running a 24-hour, 7-day-a-week service is incredibly expensive. So we need to be really clear for modelling RCHT's demand curves, if you like, about where we put that resource and how we deploy it across the whole of Cornwall and the Isles of Scilly. But it's not there yet.
Okay.
Of course, Debbie.
Thank you. Sorry, I know you're keen for time, but such is the interest in this community same-day emergency care model that Elizabeth invited me to say a few words this morning as one of the hot topics, because not only have we, at very short order, stood up the Bodmin Community SDEC as part of the winter funding, but we have made a real difference to people. But we've also made a difference to our workforce, and it isn't me sitting here saying our workforce love it. We've had colleagues from regional and national teams come in and say, your nurses love this work. So what we're talking about is a fundamental shift in culture of care as well as location of care. So these units are community nurse-led, GP-enabled services, and their focus is on keeping people at home as much as they can. So it's really linked into the investment that the ICB has also made into things like virtual wards, the acute care at home, which is where you get your antibiotics at home, the BCSE that those offers, and it's linking it all in. So the data has shown that less than 5% of the people that have come through the community SDEC have ended up going on to an acute setting, which in and of itself is amazing. But we also saw that only 30% went home on the same day. So we started to think, what have we not cracked here? But actually, some of that is because we too were seeing people coming later in the day. And so if you take the same day as a 24-hour period, or for some people, they just need 48. If you look at our 72-hour turnaround and getting people home, then you start to see the much bigger gains. And these are the frail older people for whom we know that harm will be done to them unless they get quick diagnostics, quick, rapid treatment, and then rapid turnaround to home with support that really improves their independence. And then the knock-on for future services is so much greater. So the endeavour that we're working with RCHT on now is really exciting, because this will be a community-led front door in an RCHT setting, because let's not forget that West Cornwall at the moment is part of RCHT. So it's requiring some really excellent partnership working to pull that off. but we all share the same vision, and we need to back it.
Huge interest in this nationally at the Confederation.
Good. Is it really quick? There you go.
Thank you, Debbie.
I love those quick.
There's quick and there's really quick now.
Oh, you've made me blush, Neil. Thank you.
Okay, so before we move on to, if you can keep it really high level, because we've got some time as the day goes on, and particularly on finance, but I'm taken by Rachel's question, well, not all of your comments, Rachel, but in terms of the workforce controls, can I just ask for the two of you just to comment on grip and control on that?
Dashboard that's in the pack
I'm asking a slightly different question.
shows the net effect of the controls that I understand are in place.
Are they being effective?
On month one, the data is suggesting that, yeah.
Okay, I thought we just rehearsed that, but
I'll point to the specific, if that would be helpful.
That's fine.
So just page 66 is the workforce dashboard in the IPR report. And this is what we are going to use to report against the 24-25 operating plan. We had a deep dive on the dashboard at Workforce Committee on the 30th of May. And the data that's been selected focuses on the core metrics that are being used to inform the operating plan. So with thanks to colleagues in the Trust, because it hasn't been easy to bring the data to the simplicity in which it's presented here, and there's ongoing work around that. But the key data that we're collecting is substantive whole-time equivalent, agency whole-time equivalent, agency costs, leavers, and sickness absence. There's going to be more to come as we develop our data, and we're hooked into the national and regional work on workforce productivity that's being developed. So through the year, we'll be looking to see how the metrics that are defined for that we can replicate locally, and the working group with Trust colleagues is going to be the place to take that forward. But headline on month one, if you bear with me, just in terms of those key metrics, the substantive whole-time equivalent across the two trusts is 65 whole-time equivalents below the month one plan that we submitted. Agency workforce is 68 above. Agency costs, though, are 0.1% above. So whole-time equivalent costs for agency is an interesting relationship. Leavers 0.3% below plan. Sickness absence slight increase on previous month. Obviously, this is just month one. We'll be monitoring it month by month, and we'll keep the data coming through on that basis. In terms of the conversations that we've had with Trust colleagues, there are some really important things that we need to sort. So definitely don't want to be duplicating reporting that's already happening through Trust workforce committees, and we want to make sure the sequence of the reporting works, because it is very tight from month end to producing the data, committee sign off at Trust level, and then into workforce committee and then into here. So there's some further work happening on that. And then the other action that we took from the workforce committee was about developing the narrative that explains what's going on behind the data. At the moment, we've just got the headline figures here, but the overall headline, based on what we've got so far, is on track against plan at month one.
Any other observations on this section?
I think we should say really well done, because it's no mean feat, is it,
No.
managing workforce?
No.
And we should just take a breath.
Yeah, and with all the good stuff that you kindly added going on as well.
I think those thanks need to go to the workforce teams in the Trust who are in the detail of the data, because it's really hard work making sure we got the right method and making sure that it's produced in a timely way.
And also 75% of our spend, approximately, is on people. So managing the workforce numbers is helping us to manage the financial position and the development position for the system. So I think it's great.
Depending on which hat you'd like to wear, Debbie and Steve. Thank you. Right. So let's move on. Simon, anything from your seat?
Mine will be very brief, because you'll note there's no finance information in the wallpaper. It's due, the national reporting actually as a system is due on Monday. And alongside the finalisation of our operational plan and submission yesterday, we'll be in position to report properly from Monday onwards. So routine reporting will commence at that point. As you'd expect me to say, I think the focus on workforce and CIP delivery will be the key thing for us, as with every other system. So that will be the focus of our reporting going forward. So that's it from me. Thank you.
So, Susan, when might we start to see a new version? Because we're starting to talk about whether there should be a regional IPR, and that's still a debate going on. When might we start to see something flow from that?
As soon as we've got the templates from region,
Okay.
rather than continuing to iterate the one we've got
Yeah,
now.
I agree. That's really helpful.
Yeah, I think there's a resubmission, as you say, of finalisation of operational plans that is going on across a number of systems, and I'm assuming that it's linked to that. But also to mention that there's obviously consultation on a new oversight framework for ICBs,
Yes, that's
and that we need to think that will be played into thinking about any kind of dashboards, but also ensuring alignment. Again, we're all measuring the same things.
All right. And we're going to pick that up as a group, aren't we, as the South West?
Yeah, we are. And Nim Chandran sent us an email this morning, didn't she? About starting to use the federated
Kelvin, and we'll pick that up in a second under his item, if that's all right. Okay, let's move on. So I thought I'd just wait till now just to thank you, Kate, for getting up at 3 o'clock in the morning. You probably got up earlier than 3 o'clock in the morning.
I got straight out of bed and put on some...
And getting down to us, because you've been at the NHS Confred, and it'd be good to hear some of the things that went on there later on, if that's all right. Okay, colleagues, thank you for that. I know we've run over, but that was really important. So I thought we ought to let that play out. So thank you for that. So let's move to the Senior Information Risk Owner Report. Tracy.
Yes, thank you. We're not due an update this time, but given that we've got the Information Governance Toolkit submission going in at the end of the month, just an opportunity to give a very brief update. I've taken on the CSIRO responsibilities and Molly's now leading on IG. So together we've had a fresh look at our IG arrangements, particularly in the context of our organisational redesign and the changes in accountabilities as a result of that. And I guess heightened by the cyber attacks in NHS trusts for colleagues in other parts of the country. Focus is very much on achieving ongoing compliance with the toolkit, which we have to submit at the end of the month. And there are some significant changes, particularly around staff training, that we are working through at the moment. Our information governance meeting will take place twice this month to receive assurance and agree how any risks to compliance will be mitigated ahead of our submission. And we've got probably 3 key priorities. One is around our information flows and associated information asset registers, particularly given our organisational changes that I've just mentioned. We're looking at our data quality arrangements and ensuring they're aligned with our new BI arrangements, and looking at that enhancement of our training needs analysis. So the audit of that compliance starts on Monday, and the IG group will review our proposed submission on the 26th of June, taking into account that audit, and report to QPOC in July, because we want to ensure we've got visibility of that for our committee arrangements. And then we will have an action plan to further strengthen compliance in 24-25, and that will be put in place in July. We've also been asked to ensure, by NHSE, to ensure our information systems and processes are resilient to minimise vulnerability to cyber attacks, and reduce the impact if it occurs in the context of that national and international context. And Kelvin's team are providing assurance that actually the actions that we are being asked to take have already been taken locally. So we'll take that through the information governance meeting later this month as well. And then I'll bring a fuller CSIRO report back when it's scheduled later in the year.
Excellent update. Thank you. Any questions? No? Thank you very much. Let's move on. So we'll move on to the improving value section. So as a verbal update, Simon, over to you, please, on our agenda item 12, 25, 26.
Thank you. So I'll reiterate the discussion of last month and the current thinking, and there's a commitment to bring a timeline and plan to the next board meeting, which I think we'll achieve. So we were underlying and agreeing the commitment to get a draft business operational plan in place by the end of September, with the enthusiasm to get to a point that we have early sight of what needs to change and be delivered in 25/6 with a number of months to implement and effect change. So that's the emphasis for that. That ask is also being made from finance colleagues at NHSEI to get an initial view on a plan for 25/6. So it sits well with that. I'm going to be having a discussion with the system exec group tomorrow about the shape of that plan. I'll describe it in outline at the moment, but it really needs an iteration with colleagues, because I've just shared it with a limited number of people. But that the key things we want to ensure, which are clearer than probably in previous years, are firstly that we have a really explicit process that engages our localities. So whilst there's a huge emphasis on shifting care to the right area and being able to move our resources around, that we have those engagement discussions throughout the planning process and a sort of commitment from all parties in terms of how that change would be affected. So that's an important part of it. The other part of it is being more explicit about a benchmarking review process, so that in preparation for taking a view on our priorities and how we improve services, get better value, we very mechanistically review our benchmarks from a number of different perspectives, so from a population perspective and from a provider perspective, to ensure we deliver value. And also within the ICB, we've introduced a redesign, bringing programme care leads in. So what we would be expecting is that best practice in terms of service change and how care is delivered is also brought in as a consideration as part of the planning process for 25/6. So those things we want to be really explicit. So what we've got a discussion about on Friday, and my aim with colleagues that within the next 2 weeks we've got a sort of plan we are happy to work with that sets out between different work streams of operational planning, financial planning, workforce and capacity planning, which is the triangulation between all those three, that we're really clear within the ICB and across the system who's leading on those and how that's going to be pulled together with decision points along the way. The system executive group will be the core group at an executive level that will drive that work, and we'll be bringing an update to, as I said, the July board. The key thing I'm keen that we get to sooner rather than later is that certainly over the next couple of weeks we can talk about a number of key principles that we want to work to for planning into 25/6. So that'd be whether it's service delivery principles, financial principles, the channel shift principle, and how we can describe those in a way that are really clear and drive us in a direction that we think meets our strategic direction as an organisation. So that's a brief summary of the thinking so far. There's been limited sharing of that. We've allowed ourselves to get the final submission out of the way yesterday. So the work of the next couple of weeks is to be really clear about that detailed planning process that we'll be bringing to the board next month.
Can I just raise some key risks in our planning for next year? So there are some things that we've started doing this year that we need to retain in order for next year's planning to be effective. So the GP hubs that were set up during the course of winter and started to have a practical impact around easy to manage presenting conditions going through the GP hubs, holding our GPs back for continuous care and for complex presentations. That is the core, the bedrock of specialty management of long-term conditions out of hospital. So those GP hubs need to be able to start taking diabetes, respiratory and cardiology from next year with our specialists embedded in the hubs. And again, I'll do a bit of a download from the Confederation later, but several people came to get hold of me to say that the hubs that we put in place over winter, A, look exciting, and B, look like they'll be able to handle more things. So the challenge for us this year isn't just to deliver the plan, it's to deliver the plan and reshape our system. So we just need to hold ourselves true to that, because we're going into Q2, and that's where the rough stuff is going to start happening. So.
Okay. Thank you. Debbie?
So it's a question for Simon on this year. So I know that before Kate's leave, she and I tasked you and my team to ensure we've got a contract in place by the end of June. And now a national mandate has come out, I believe, for contracts to be signed with providers by the 6th of July. So I know that's a tactical this year thing, but are we on track to achieve that, Simon?
I believe we are on track to achieve that. We have to do a sort of major update to our NHSCI tomorrow. And from the details that have been shared with me, both with RCHT and CFT, we're well on track to get to that position.
Thank you.
That's really important because the NHS has got a little bit of a habit of not signing the contract, which actually puts providers at great risk because it isn't a roll forward, it's a roll forward at whatever you were paid for last year. So we just need to make sure we've got all of that done and it's just then.
Thank you, Steve.
Two things. Firstly, just say welcome Simon's update. I think it's really helpful, and it's starting to deliver that ambition that you challenged us all on, John, about bringing that process forward by at least 6 months. So I think in itself that's really helpful. Secondly, I think that's a step towards one of the other things we talked about previously about can we start to bring the medium-term financial plan to life and start to describe now year by year what do we mean by channel shift, so that we're not even just looking at next year but looking a little bit further ahead. So I think that's been really helpful. The final bit is just a question for me. I found the NHS England productivity reports last year incredibly helpful to bring challenge and clarity in some aspects. I think the last one we had was month 10 last year. I just wanted to ask Simon if we know, is the intention for those reports to continue or is there anything we need to be aware of if they're not going to be continuing?
The intention is that they are continued. I think they are reviewing some of the metrics, but it'd be largely in line with what they reported in the past. There's certainly been a slight delay in the month 11 reporting because of all the planning arrangements that have been happening over the last month, but we're expecting to continue that.
Thank you for raising that, because I wanted to make three points which feed on lovely from that. I wanted to thank everyone for the collaboration to have got to the point when not only can we have got to the current budget, but to have actually started talking about next year so early as we have. That I think goes right to the core of people being able to work together. On the productivity point, I think it is important we all have complete transparency, such we all have the same information. Therefore, as working on the assumption that information is coming out, I know it goes to FMP or will go to our FMP, but it must be shared. So I think each month we must have the discipline, if it's all right with you, Simon, we actually add those packs. Is there any reason why we can't add those packs to here? Does that work for you?
Yeah, absolutely. And I think I assume we'd be seeing that through system executive group as well. Yep. So we've got that kind of executive drive ownership, as well as the ICB committee and organisational work.
Yeah, because I think it's just worth reiterating. It's our collective responsibility to recognise that our benchmark is still March 2020. That everything's been taken to, and therefore, we as we get into the planning cycle, is to look as to how over our medium-term plan we look to shift the dial towards that. And as part of that, Simon, you were going to just share with us, because we've still got month 10, as part of the planning cycle for 24-25, I think it's helpful for us to know where we're starting on the 1st of April, 2024, and what the goal is on the 1st of April, 2025. So I think you're going to have that available in the next few weeks, is that right?
Certainly by the time we report to the July board, we expect to have a
very good. Because that will give us some metric as to how ambitious 24-25 is from our starting point. And then we can start, as we enter September and October, start to have a date about how ambitious over what time frame we can be to move in terms of outcomes and productivity. Yeah,
I think that's absolutely right. That is in the plan. So I think all systems have had back from NHS England regionally the impact of the total plan submission on productivity. So we have that metric. That shows a increased level of improvement in the Cornwall and Isles of Scilly system compared to the regional average, which is moving us in the right direction. I don't understand, not in any way wishing to be difficult, why we haven't got month 11 or month 12 reports at this stage, so I don't know whether there's a capacity issue. I don't think this sits within the ICB. So I've always struggled with why is it taking so long to have the productivity information?
I'm going to guess that the back end of last year was so fraught around getting the money to a level where the NHS was viable that I suspect that just the routine reports haven't come out. But if you would chase them up, Rachel, and then we can bring them back retrospectively.
Because it is coming from NHSE, correct?
Yeah.
There is dialogue about them becoming monthly, because they're always bi-monthly, which wasn't.
That's why I was asking the question. We will get this monthly, because then through our Chief Finance Officer, the opportunity to speak to the national and regional team to say, come on, we need this each month on a metronome basis, and then we can all have one version of the truth, which we've all been seeking for a period of time. And if I can turn by you to Margaret and Debbie, when do you think productivity on CFT, the metrics, are likely to be coming back as part of 25-26? Is that...
So if I can respond from a CFT perspective, so it's well rehearsed here, isn't it, that there are no currently nationally recognised productivity metrics for the mental health and community services. That said, we have set our own teams the challenges of doing that, and we have now implemented what's known as PLIX, which is patient level costing system, so we can now compare activity, workforce, finance from Q4 22-23 with 23-24, and we're looking now at how we can demonstrate productivity, and we'd like to offer a suite of metrics to come through. So it's what we don't want to do is reinvent the wheel, because we know that nationally folk are looking at it, and there are different ways of counting some of our activity. So we think that we just need to come forward with some measures, but it will be a work in progress, I think, over the next couple of years. And Rachel may know more about where this is headed, but there are 3 community and mental health providing organisations, Birmingham, Cambridge and Peterborough, and CLCH in London, that are the forerunners of this.
I think this is part of the reason why I'm raising it, because there's no point us working on something only to find out that somebody else is going to be viewing us with a different lens. So there's something for me about going through Simon as a to actually get.
If you take something like talking therapies, it's a national formula, so it wouldn't be that hard for us to say, actually, this is what there is for that. But some other services, it's much
You
more
want to land it with region.
Yeah, there's a big piece of work. I mean, Simon, there's in the region, they're trying to, as you say, coordinate a piece of work, both picking up national work, but also thinking about what measures we have access to in the Southwest without creating a whole new suite of measures. Interestingly, length of stay is a very generic measure that is one of those where actually it does tell you a lot about productivity. Intuitively, it doesn't necessarily feel right, but certainly our performance colleagues will tell us it is. So there's more work to come on this. I think it'd be good to focus in on it.
So would it be reasonable to have an update in September?
Yeah.
Yeah.
Yeah, and I would be happy to sign my organisation up to being part of that update, recognising that it
really
would
helpful.
be a full suite
Really
of measures,
helpful.
Chair.
Thank you so much, Debbie. Thank you. Okay. Anything else? Any observations? Great teamwork. Thank you. So at this point, we could have had a coffee. So those who would like either a natural break or a coffee, can you try and go one at a time? Because, all right, because I'm very sensitive. We have some external colleagues joining us, and they are time bound. So that's hence why I was trying to keep us on schedule today. So if you do need to pop out, please do so. So we have moving on to the digital strategy. So Kelvin, I've asked you, take it as read. I know you want to say a few things. I know that Steve kindly gave us a view on the network issue. Did you want to add anything to what Steve said earlier before we get into this agenda item?
Well, thanks, actually, because I think building on Steve's helpful description of the operational challenges that the incident has brought, and actually Tracy's comment around the recognition that there's a heightened awareness of cyber at the moment. That's always in the front of our mind when we have an incident. And obviously particularly so at the moment because of the problems that the London trusts have had. We were very aware, obviously, at the beginning of that. The London Trust has widely trailed in the media, is what's known as a supply chain attack for them. So it was their supplier that was attacked. We don't use that particular supplier for our services in Cornwall. So from that perspective, we had confidence that that wasn't likely to be a repeat scenario for us. But we absolutely, as we always do, set our cyber team working alongside the networking and other technical teams. So the cyber team was very focused on, is there anything to suggest that there's a cyber attack? As soon as we recognised that we had problems, they were able to diagnose within about an hour with a high degree of confidence. We weren't seeing any signs of cyber activity. So the focus of the incident from then on was very much around finding and resolving the incident. The actual technical problem that occurred, we found and actually mitigated that within a couple of hours. But as Steve has said, when you have an outage of that level, it then does take a number of hours to recover. And lots of the systems came back quite quickly, but we are talking about hundreds of systems on the scale that we operate. And so the disruption did run into the next morning and has subsequently been mitigated, and operational colleagues have worked fantastically with our team, particularly around how quickly they went into their business continuity measures. Jointly, people worked out very quickly, this was a serious incident, we will invoke business continuity, and they literally picked it up and started straight away. So I think we did actually mitigate what could have been worse operational impact by that responsiveness from colleagues.
Okay. Pass our thanks on to you and your teams and all the operational teams who went through the business continuity. Can I just be quite clear? Was it just RCHT and CFT? Because there's been some correspondence suggesting it impacted on UHP and GPs. Could you just clarify that for me?
Yeah, so it did affect all of our services across Cornwall. So we actually, as a shared service, provide services to all the health organisations, and that was why it was a very large-scale incident for us, because the nature of it did affect all of our partner organisations. That is very rare. We've been operating on this basis for over 20 years. It's the first time in over 5 years, in the time that I've been here, that we've had something of that scale. Again, we'll be looking at it very carefully in terms of the technical root causes. Yeah.
Thank you.
Just briefly, John, in this public board meeting, I would like to take the opportunity to apologise to any patients whose care was impacted. Our teams have sought to do everything possible to mitigate that, but it is the case, as I mentioned before, that a small number of patients did have either an outpatient or, in a small number of cases, a surgery cancelled, postponed or rescheduled, and of course that has an impact on each and every patient. So I'd like to pass on my apologies to anybody who was impacted, and we're taking every possible action to provide those arrangements. And secondly, to say thank you to everybody who's been involved in the response, operational, clinical and other teams across the system, and to our SITS colleagues who all worked incredibly hard to bring things back online.
Yeah. Thank you. Yes?
I just wanted to check, Calvin, although you're probably looking into it, and is it something that you, without detailing the cause, that you think would be preventable in future, having understood what the issue is?
So we've got early root cause, which actually does give us comfort around it being a very rare event. Actually, in the part 2 session, I'll be able to talk in a bit more detail about the technical underlying.
We'll come back to that, I feel, as the afternoon goes on. Okay, thank you very much, Kevin. So, here we are. Digital strategy. We're not here to decide. We're here to be critical friends in terms of where it's going and add value to you. So, feel free to take us on the journey of your digital maturity, progress and strategy thoughts.
Yes, thanks, John. And actually, it's probably helpful to have that context of, when we look into the future, we're also having in mind that actually we deliver operational services every day, and they are critical enabling services. So I'll be using the phrase enabling a lot, because that is the nature of the work that we do and how we're thinking about digital transformation. The paper itself it's focusing on one aspect of our strategy. Again, the strategy is very wide-ranging. So the paper is focusing on, absolutely fundamentally how citizens use our services and how they're going to increasingly be using services in the coming years. My team currently supports about 15,000 people across across the health and care system, we now regularly talk about over the coming years, as we deliver more services digitally to people across Cornwall, we'll have a user base of several 100,000. So already our thinking is about how our services touch the people of Cornwall as well as all of our colleagues who work in health. There's obviously a few examples in the paper, and I'm sure there'll be questions around those particular examples. But again, trying to draw out from that, I think the really important point was there's a commonality between our local needs to listen to what people need locally. And as Neil mentioned right at the beginning of the meeting, something as simple as somebody would rather have a telephone call than some other form of appointment is really important. And we need the digital capabilities in order to actually store that preference and respond to it when people are interacting with it. Sounds really simple, but actually when there are so many touch points across the health and care system, actually there's a lot of complexity behind that to actually meet those needs. And it's meeting those sorts of needs that actually are measured on the national level around our digital maturity. So at the moment we can do limited things around supporting preferences. We need to get to that position where somebody actually registers with us. This is how they like to be contacted, and we can consistently respond to that across the whole system. So those are the thought processes that are really shaping what we've got in the paper. And actually, there's also recognising, although digital is an increasing part of all of our lives, as people rightly always tell us, some people struggle to engage with digital services, and so we've covered in the paper that actually we need to do more and more work around digital inclusion and providing the support mechanisms for people who find it hard how to engage with those capabilities. But those are the kind of driving thoughts. Really interested in the feedback and questions from everybody, because that will help shape and develop those thoughts going on. And just one last quick point around the agenda item that follows. That's a nice lead into, I think, future updates around data. So we'll be learning about a national initiative in the next item that will help shape future thoughts around data as well. But very happy to take questions. And then at the end, I'll try and summarise, I think, what I think it helps us with in terms of our awesome board colleagues as a whole to take that forwards.
I'll kick off if I may.
Yeah.
I think it'd be quite helpful to try and understand as we go forward over the next few months, quite what will this mean in terms of what patients, but also, I can't think of another way of putting it, non-patients, non-users, whatever else, in the prevention side of things as well. What are people going to, so my first question is, how is it going to be different for the 550,000 odd people in Cornwall and the Isles of Scilly? And my second question is, there's a grave danger with technology and digital that operation teams see it as, well, that's the IT team doing it. How do we make sure this is actually technology that actually helps drive change of work practices, that actually makes things faster, slicker, more efficient and better for staff and for patients? So two different types of questions.
Yeah. So around how things will be different for people that use our services, again, it's useful to kind of note that we're not starting from nothing. COVID brought an enormous change around starting to provide things like virtual consultations and actually things like the patient portal we have in RCHT, which does provide both a portal and access through the NHS app. All the feedback that we've had around those sorts of services, noting the portion who struggle, but the vast majority who've been able to access those capabilities, we effectively, I think, see no end to the growing demand. There's a definite hunger for people to be able to interact with our services in the same way that you interact with many services across the rest of their lives. And I think even very simple things like being able to get your appointments electronically, actually getting them within a few hours of having a discussion with the clinician, and then actually being able to make changes to those are the sorts of things where we've got some capabilities in that sense at the moment in RCHT, but we need to make that more universal across the health and care system, because you interact very differently with the acute hospital to your GP practice or CFT. And I think the work that Lucy's been doing around engagement across Cornwall provides a huge opportunity for us, I think, to get that direct citizen feedback on what they find difficult. And we've had a few examples of, our websites are sometimes hard to navigate. But actually to involve the people of Cornwall in designing these services, which I think then very much comes to the second point, John, around we can't work in isolation in the technology world. The service design for those new services can't ignore that drive for digital. So we've absolutely got to bring together our clinical colleagues and ops colleagues who are designing these new services, us as enablers, but critically, I think our citizens.
Is that process in place for engaging operations, or is that about to happen? Just before I bring in Tan and Stu, just.
So I think we do in a number of ad hoc ways, but we absolutely need to work together, I think, to get more rigour around that.
Thank you very much. Tan and then Steve.
Yeah, thanks. Kelvin, I think it's a really great opportunity here for us, isn't it? And it's how we actually deliver this, not just so that we get some really great whiz-bang tech, but how we actually deliver it to make a difference for outcomes for people, and within that for all people. I think we need to look at equity of outcome here in terms of people's health conditions. And I note in the paper that you've got some stuff around digital inclusion, but for me it's actually more about digital. It's about that equity of outcome that's really important. That we don't just deliver for the worried well, but we actually target some of our resources to those people that are some of those in most poor health, and some of those who are excluded from this from good health.
Thank you. Kate, can I invite you to respond to that?
Yeah, so being away from work for one, having time to think is a luxury, isn't it? So Chris and I spent quite a lot of time talking about work that he did in New Zealand. I've got a Zoe app on my arm at the moment, and it's I am obsessed with my blood glucose. And one of the things that we were talking about, so it's 250 quid for that Zoe app to be impressed with your blood glucose. Why aren't we offering it to people to give it to them for constant glucose monitoring, so that they start to see their own trends and bring groups of people together, health coaching in communities using our health and development workers. So I think Tom Lafferty, I think about 4 years ago, did a digital visioning event, got people together from all over the peninsula to say, this is what we've got, these are the technologies that are available to us, how are we using them? And I don't know whether now might be a time to think about how we do that again, but involving people who use services around the technologies that are around, how people could use them. I mean, Chris was talking about deals that have been done with phone companies, so that people have got the phone with the app on it, they've got the kit, and we make it an exciting and fun thing to do, not just, being told to eat less, whatever. So
very good. That's really changing the dynamic. Steve, and then Mary, and then Neil.
Really helpful work on this. I've got a kind of tactical view and a strategic one. So tactically, it's still the case that in some instances, the way you get a GP appointment in Cornwall and Arsacilly is phone up at 8 o'clock in the morning alongside 100 other people, and if you're lucky, you get through and get an appointment. There'll be other examples, and you talked about outpatient booking in RCHT, where it will take some time to get that kind of clarity. So there's a question for me about how does this strategic intent enable us to transform those sorts of examples now? And then to come to Kate's examples, I think this connects to channel shift. So when we talked about channel shift previously, we've talked a lot about channel shifting from the acute into the community, which is critically important. I think it'd be helpful if we can describe our ambition for channel shifting from a digital perspective into prevention areas that Kate's just described, but into how our whole services work, how they're coordinated. So I'm assuming a radical transformation for colleagues across our health and care system, and a radical transformation to empower our patients and users of our services. So that strategic transformation, are we able to bring that to life about what that means in terms of channel shifting into investing in digital services and transforming as well?
Going to come in because it ties with conversations we're having, isn't it?
Yeah, so I think I totally agree, Stephen. So at the highest level, I break this down into, when we look at a clinical digital strategy moving forward, is it better for the patient? So your point about appointments, is it better for the user? So how does it make the clinician's day more efficient and more of higher quality? And is it better for the system? How do we use the data then to ensure what we're doing? But if you target on the patient side of things, you know, it's about really good quality access to the notes. So they're their notes and they use them. It's about access to appointments. It's about then using digital to give information that improves their health literacy and their self-learning, and using the technologies that Kate describes becomes quite exciting. And then if you take a population approach to that, we might and risk stratify our patients in terms of deprivation and those, you know, what I would call unmet need or unworried, unwell. We should be targeting resource and investing in these technologies to address the unmet need, whilst also promoting it from people who are just generally keen because they have a higher health literacy. And I think that's why I think to talk about a digital strategy, you always have to think about the impact on the workforce across the system, not just in the acute trust, but in the community. That becomes exciting because it's about working together. Actually, it has an impact on the estates as well, because actually we might find we can use our estates in a different way because the digital offer and how that, you know, impacts on the patient will be huge. And the big ticket item that was talked about at ConFed yesterday, and Kelvin and I have also talked about, is the AI implications of this. So how, you know, it's not that far away that, you know, someone who's diabetic will have almost 24/7 excellent clinical access through an AI tool to help them manage their diabetes. So that will change how we use our workforce.
So actually to make that, sorry, John.
Yeah, what I love about this topic is everyone's really keen to contribute. So I can see us having another day almost on this kind of thing. Mary.
Yeah, thank you. I think this is really exciting, and you're right, we could talk about it forever. I just got a couple of points I want to make. One of them is, unlike what we usually face in Cornwall, which is an increasingly elderly population, in this case, it's almost the inverse, because we're going to have an increasingly digitally able population as time goes on. So I just wanting to be sure that our strategy includes projection into having much more able people. I do think the points that we've already raised about inclusion is important, and forgive me for also raising the point about and how are we working with providers of Wi-Fi access, because that is a point of exclusion in Cornwall, as you all know about my problems with digital, but I wonder how we build in that very differential inclusion of access.
Yes, we touched on it this morning. Cornwall does actually present some really significant challenges around connectivity, and part of that is, of course, all of the service operators who are interested in delivering a service tend to measure on the basis of percentage of population they cover, and of course our geography and relatively small population means that actually, although you can see metrics that actually show we've got good coverage, I always say you can have 5G coverage, you know, in the middle of Truro, and barely half a mile away you can have nothing if you're down a deep valley. And we touched on that. So I had some conversations with the X-ray car team, who initially were struggling because they need to be connected wherever they are, but actually explored a couple of solutions, and actually they have now got a solution which is helping. It's not 100% perfect, but they're getting much better coverage by actually connecting out to multiple networks, not just one, because again,
Just wondering, Tracy, maybe you could help me on another day on this. There's something about both the ICP, because it's got wider health determinants, but I'm particularly thinking about the Cornwall Leadership Board with its wider leverage of who attends that. So if we could pick that up and agendarise that and ask our colleagues there. So let's move to Neil. Neil?
It's just to ask about whether you see the strategy involving what I would call the trust of users, and in this I'm talking more about staff and people working for patients, in terms of eventually having personalised care record, treatment escalation plan, advanced care planning available to them. Because you can have all that, but if people are not using it, inappropriate decisions are ignoring people's wishes. And we have some data that may have happened, and there are reasons for it. But if you involve the staff now and find out why they're not always checking, using, trusting, is it updated, that kind of thing, I think it would be really helpful, because that should negate people who are not having their wishes met.
A really key point, that actually ease of use is very often behind those things. It's widely recognised in terms of public adoption of services, and so kind of well established in that world. Less so, but changing in terms of the systems that we use amongst our colleagues. And so I think the exciting opportunity in terms of the strategy is the clunky systems, I think, as our staff would call them now. You can see a roadmap for those getting better. Our strategy is to reduce the number of systems, because that's the real problem for clinical colleagues. If you've got to have half a dozen systems open at the same time, it's really, really difficult. So our kind of obligation to help that staff issue is to make the systems easier to use. And then I think it is that one then of working with clinical and ops colleagues. So actually it's the norm that colleagues help each other.
So Kevin, the reason why I'd like to pick up on Neil's great question and the point I made earlier on is I'm trying to think of an easy way to frame this. It's difficult when you're used to doing something to know that actually a bit of kit can transform what you do. I'm trying to think of a good example, but AI is going to transform everybody's way of thinking. It's a bit like probably, the typewriter to the computer, but probably this is going to be even quantum beyond that. I would like you to take away the thought, which is, how do operational teams actually get to know the art of the possible? What might this do? Because, my perspective might be I could take it from 1 inch to 2 inch, but you could say, well, crikey, if you 2 X, Y, Z, it could be 12. How do you bring that challenge? So not for now, but that's where I was coming from.
I think the example of it is the checkbook.
Oh,
so
yeah.
None of us have a checkbook anymore, I don't think. And who would have thought that?
Oh, chip and pin, here we come.
Yeah.
Or even tap now. Okay.
Still use a checkbook, Neil.
Okay.
Yeah, thanks. So, I can give a pretty good example of that, I think. So about, I think we're pretty well advanced in general practice and primary care in terms of digital and tech. Obviously, I've had completely digital records for years and years. But about 5 years ago, we started doing electronic prescribing. So people used to have to come into the surgery, get a prescription and take it to the chemist. And now all we do is send everything directly to the chemist. It's better quality, there's less errors, and it's much more efficient. And I think electronic prescribing in hospitals would be hugely advantageous. It would, imagine from your outpatients clinics or stopping patients waiting for TTOs from pharmacies, just send it directly to their local pharmacy. My point wasn't specifically around electronic prescribing. It's about sharing knowledge, really. I think general practice is a really, really rich environment with loads of experience of implementing tech and of working with patients to iron out inequalities around tech. So I just sort of make a plea really to come and have a look what's going on in the community with tech. I think you'd be really surprised about some of the amazing stuff and the incredible efficiency drivings from implementation of tech in Cornish general practice.
Just as a thought before I leave, great point, Stuart. Lucy, we haven't had a chance, you and I, to sit down with Kate yet and talk about the AGM. But some of the thinking that we've actually got already is to talk about how the big ticket items that we're going to be using to move things forward. As to whether this is an appropriate one, the more I hear the debate, the more I think we need some quality time as a group, maybe as a development day or something, to actually focus on this kind of thing, if you're up for that.
Absolutely. And I think Stuart's point, I think try and bring some tangible examples. Yep. So the Brave AI project, which is jointly with primary care.
Yeah, and we should be showcasing things like Stuart's raised if we're doing that. Okay, thank you, Nick.
Yeah, so thank you. So a little bit building on what Stuart said, I've been having worked with EPS for, I think, probably 15 years, Stuart, actually, but which is frightening. I'm moving to a jurisdiction who don't use it anymore and was there last week. That's quite a jump backwards. A couple of challenges, and I say this framing by being a huge supporter of the digital strategy, the enablement and what it could do for people. A really simple question. In the paper, it says there's 186 digital champions, 51 member organisations, and then it talks about devices. How many of those are in primary care?
So that's describing a service that council colleagues operate. And what one of the things we're keen to work with our council colleagues is because we're providing some support through some NHS funding, is to get that service more directly into health settings. So it's a really good challenge. I think I'd like to take that away and work with council colleagues.
You're smiling.
And the only other reason that I would say that, is when, there's some great stuff like Clinic that have been enabled in GP practices, but the number when I do my other job as a frontline pharmacist, the number of people I've had to sit down with in a consultation room and walk them through it and do it for them to make sure that that equity of access is maintained. I think, you heard Amanda Pritchard say earlier that we talk about channel shift, bedrock of primary care, most interactions, what that means and how that's done and how that's delivered, and the people that deliver that in the widest sense of the care, from all the people that Stuart employs to wider primary care and those most point of access, upskilling those people that can say when they come in and go, what does this mean? What does that mean? What does that look like? Because they're the questions you get all the time. If you've got that level of resource with council colleagues and nuns in primary care, I just put that as a challenge.
Very good. Thank you very much, Nick. Emma.
Thank you. It's a really exciting opportunity, and Kelvin and I have had a number of conversations, particularly about case management systems. So I've got 2 points really. One, to build on the point that Kate was raising around us making sure that we're not thinking about existing systems and how they're a bit better to use, but actually thinking about that prevention health creation. And things like Zoe are lovely, but let's be honest, they're for people who can afford them. And actually what we should be doing is we should be putting them in the hands of people who can't afford them and need them the most. So I think we really do need to be looking ahead to see how can we expand that kind of digital health prevention app opportunity. But that has to come with it, picking up on Chris's point about health literacy and activation, it has to come with its appropriate support. So if we know that people have different levels of activation and different levels of knowledge, skills and confidence to utilise apps, and then to actually have the motivation and the all of the conditions in their life in place to be able to make the changes that they may want to, that requires additional support, and people with very low levels of activation need much higher levels of, often regular touch points where they're supported, motivated to make those changes. So we can't just see digital in isolation from wider community support. I think there's a real opportunity here, and you've alluded to it in the section about digital wellbeing hubs to build on existing infrastructure. We've got a great infrastructure around community hubs, some of which are already doing digital inclusion work. So building on that would be brilliant. And we've got some great VCSE organisations who are already going into hubs and elsewhere to deliver that digital inclusion and upskilling. And interestingly enough, just from a personal perspective, my local patient participation group regularly sits in the GP practice and talks to people coming in about how they can book on using the GP app and the NHS apps, and they're just volunteers and they know it needs to be done because it's a big issue. So I think thinking really broadly about who are the people out there in our communities who we could be using as part of that workforce, if you like, to really upskill people with the basics around digital technology would be really interesting. And finally, just picking up on the point of the case management, so the kind of internal piece, we're seeing more and more collaboration in the voluntary sector, and I know the channel shift conversations that we've been having at board, and hopefully we will continue to have over the coming years, will mean more and more of that. We operate on a case management baseline, which is probably 20 years behind where NHS and council colleagues are. So we've got a mixture of some organisations who've got case management systems and, quite frankly, some who are operating on spreadsheets and Word documents. So we really want to do more in that, and I think there's some real opportunities for us to come together, particularly core partners in our sector who are collaboratively delivering services across a whole range of different NHS England or NHS funded services, but that's going to require investment, and we do need to be building that into our digital strategy.
Thank you for those contributions. So Sanj, just before I bring you in, I've noticed that Nim, our external colleagues, waiting to join us for the next section, Kelvin. So we'll just take Sanj's. Are you sure?
Already been addressed, yeah.
Oh, no, that's very kind of you.
Just apologies, I support all of the conversation, but was struck a little bit with, just reflect back to cyber security. And in that complex environment, whether that starts to escalate our cyber security risks. So not necessarily for a comment today, but there's something about then bringing that discussion and that intent back into, does that require us to take any further actions from a cyber security perspective?
So obviously the focus today was very much on citizens. In our other work streams, we're constantly working on the infrastructure implications, which is obviously where most of the cyber risk lies. That's very much the front of our mind. One of the reasons for simplifying the number of systems and modernising the infrastructure is that's one of the fundamentals of cyber protection. Keep everything as up to date as you possibly can.
Lovely, thank you. So you'll have the chance at the very end once we conclude all this, but would you like to introduce Nim, please, in the next section?
I'd like to introduce Nim and his colleague Amy. So Nim's going to give us a presentation from NHS England today on the Federated Data Platform, which is a national programme providing new data capabilities, which actually they're going to be made available and supported nationally. But a really important point, which I know Nim will draw out, is but also provide local capabilities. This is an awareness session today, but what we'll pick up going forwards is how do we make sure that our strategies cover, as ever, that local need, regional need, and national need, so that actually we manage data on an effective basis.
And welcome, Nim. Thank you. This is such an important issue, as you can see on the. I don't know how much you heard about the previous discussion. Have you got your slides ready to share? I'm just conscious, colleagues, you might not have seen them until very late on your board portal. So, are you presenting them?
Yes.
Okay, thank you. Please leave enough for Q&A at the end, please.
Will do. Okay, brilliant. Thanks for having us, everyone. I'm mindful to make time for Q&A afterwards, and if people introduce themselves as they ask a question, that way it will be helpful to sort of contextualize the response. So as it was said earlier, so my name is Nim. So I'm working on behalf of NHS England in the role I'm in currently, essentially helping trusts and ICBs adopt the NHS Federated Data Platform, or FDP. It's a considerable investment that NHS England have made.
Sorry, one second, Nim. We've got 4 slides up on the screen.
Oh.
I don't know whether it's inappropriate.
No, Pete, just says
thank you.
Thank you.
Apologies, Nim. It was our end. Please continue.
No problem. So yeah, helpfully said at the start of the meeting, the idea is this considerable investment NHS England have made is ultimately to drive considerable improvement in data capability locally, regionally, nationally. The current focus naturally actually is local adoption because the national data capability is completely, in a way, predicated on how well adopted the FDP is locally. So this presentation essentially is to help drive that local adoption. Right now, I would say we're in the early adopter phase of the FDP. And so NHS England is looking for at least 25% roughly of the NHS, so providers, ICBs, to initially drive that early adoption and drive a lot of considerable benefits to patients and staff and the organisation to help build the sort of long-term vision of the FDP, which is ultimately to have all trusts and ICBs and providers of care into the NHS with an FDP tenant, which will, it's a bit of a chicken and egg, but the more trusts and ICBs that sign up, the more benefits that can be generated through that economy of scale. So if we go into the slides, if you go to the next one, so you'll probably recognise at least some of them, if not all of these challenges that you face locally. I work with a number of trusts and ICBs in my sort of day-to-day job, and this is a very sort of common pattern. Data being disconnected in separate systems, they don't speak to each other. It becomes quite painful then to extract the insight. As part of that, the data extraction is very manual, and therefore it sort of drives a real sort of challenge. Low quality data as well, in terms of being able to sort of process it and then use it to drive the right number. So in this example, 2 different figures related to length of stay. Difficult to harness that insight on the back of it. So, the sum of what I've just described on the first 2 challenges means you can't really drive helpful insight using the data, or at least there's a limitation on that. And then that's the sort of last point made on this challenges slide. So I imagine people recognize these slides. I won't, or these points, so happy to pick up specifics in the Q&A. So if we carry on to the next slide in the presentation. So the FTP, like I said, is a considerable national investment, and the idea is there will be a national NHSE instance, FTP instance, a local trust one, and a local ICS one. The word federated is really, really key, because the idea is all data is locally sort of controlled and owned, and the only way it gets shared between FTP instances is through a data sharing agreement. So the idea is eventually things like everything from single PTLs, where you need data sharing between organizations, how you potentially provide your reporting international, so your SIP reps that go international, and everything in between become unlocked once instances are set up locally at ICS, Trust, and national. But the main thing is, like I said, the data is controlled and owned locally, hence the term federated. That's what this slide really covers. If we move on to the next one. So I'm going to just ad-lib a little bit on this slide. This was the original business case that NHS England took to Treasury. It was based on 5 things. You'll see things like supply chain and vaccination immunisation. So the timing of the business case was actually around sort of 2020, where you can imagine supply chain, vaccination, immunisation was a very, very prevalent topic. I think the challenges still exist, but more and more now, the challenges are pivoting into topics like productivity and how the FTP will drive productivity improvement. Elective recovery is a strand, if you will, of productivity and access, as well as care coordination. So you'll still see productivity threads, but there's a more recent, very overt pivot of how the FTP is going to support the productivity agenda, which I thought is important to make clear as well in the presentation. If we move on to the next slide. Right now, the focus, like I say, is on 4 products. So the main thing I just want to sort of point out is these are not just the only products that exist on the FTP. There are a starter pack that came from very, very early pilot sites that developed products that were based on problems they were facing, which were things like getting better at theatre scheduling, waiting list validation, data quality around the waiting list and the elective patient pathway, and more recently, real-time sort of task management around discharge planning for your sort of non-elective pathways as well. So you can sort of see those sort of 4 products that address very sort of prevalent challenges now when we've worked with NHS trusts. The thing you'll see at the bottom is trusts, ICBs. There is a roadmap of future products that are being developed to address even more prevalent problems. And like I say, the productivity agenda is now shaping and pivoting where that product development is going in NHS England. I think I want to make a point really clear here. People will always ask about, what does this cost? And therefore, what's the ROI? The main benefit, I think, genuinely, is the cost and investment of this federated data platform is being bared by NHSE, right down to local adoption, deployment, change management support for the trusts and ICBs that adopt this early. I think right now, that is the support package that NHSE has budgeted for. I be sort of open and honest and say, I don't know what the offer will look like in a year's time when the early adopters have sort of got the march, and late adopters may be in a position where they are almost funding their own sort of support into deployment. Because I think the reality is the FTP is probably coming to every trust and ICB. It's a good thing to consider early. Like I said, the early adopters are in the privileged position, I would say, to get the best possible support available, and they're able to have a degree of autonomy in shaping what further products get developed in NHS England by being something called an incubator site, which I can touch on later as well. If we move on to the next slide. I think restates challenges that you all maybe recognise around your waiting lists, if they're manual, low visibility, the products and what they do. So low visibility and manual waiting lists, that's sort of improved and affected by the inpatients product. Same thing around sort of theatres and clinics. There's an outpatients product that sort of addresses those kind of issues. Inaccurate RTT tracking. So there's an RTT product that's focusing on the issues that you might see around patients lost to follow-up, for example, and then understanding and getting visibility on blockers to discharge and reducing length of stay and bed management. There's a sort of discharge product called Optica that has been commissioned nationally. So these are the nationally commissioned, locally available products that are sort of free of charge. If I give you an analogy, sorry for any Android users, but if you think of the App Store, there are homegrown apps from Apple that are free. And then eventually in the future, there might be sort of better products as part of a marketplace that might be charged. But obviously, there's a huge financial benefit, if you will, or cost benefit of using the NHS homegrown products because they will be free of use. If we move on to the next slide. I think I've mentioned this, how much support is being offered. I would call this like the gold standard of support that NHSE is sort of laying out to trusts and ICBs who fall into the early adopter category. So the actual deployment of the platform, the local FDP tenant, as it's called, being able to develop the self-serve capability as well, delivery resource that I mentioned, change management, training, etc., and then eventual sort of plugging into the national sort of FDP Centre of Excellence. And again, sort of the early adopters will be sort of front of centre of being part of that group of FDP adopters. So again, early adoption, I think, is a really important key consideration. If we move on to the next slide. I think the impact seen so far is clear. So like I said, there was a set of pilot sites that helped generate the products that you see in front of you today. Trusts like Chelsea and Westminster, Northampton and Kettering, trusts that were very, very early on the FDP journey. So that's where the products and the case studies have come from. So you can sort of see the specific benefits that they see are on average. So this isn't a even really stretch benefit. This is the average benefit seen where adoption has occurred within a product. So you can see the 6% improvement in theatre utilisation, 190,000 waiting list removals. You've seen the sort of validation point, about 375,000 RTT period validation, a 253% increase in RTT closures, and then you can see the average reduction in delay days around discharge using the Optica product. So these are, very sort of in isolation, very useful to sort of see these stats. I think to achieve the maximum benefit of the FDP is heavily tied to how many products you need and therefore can deploy, and therefore how much cumulative benefit you can deliver across your RTT pathway, but also within your non-elective and your discharge planning and length of stay. And if we move on, I believe that might be the last slide. So I think next steps, just to sort of bring this to a head, there's a series of steps that now happen. This is a very sort of early stage of engaging with trusts and ICBs around this process. What happens after this is something called a technical readiness, which is basically, do you have some of the requisite sort of architecture, data to sort of plug into and set up an FDP tenant? It would be quite difficult to not pass that assessment. There would have to be quite a considerable blocker in your technical architecture for it to not go through, because NHS England are working very hard at making sure every local issue is really able to be overcome. So I would imagine it's quite rare trusts or ICBs fall into that bucket, and you can see the benefit delivery point. So I would say there's about a 2 to 3 month sort of technical deployment, but then once the infrastructure is in place, there's a sort of 12-week sprint to release benefits really quickly. Ahead of that, Obviously, if it helps with your decision, there's a point about being able to demonstrate the product. So technical product demos, which you might want to do with your exec colleagues, NEDs, but also more importantly, the frontline staff who will eventually be the ones using it to derive the benefit. So that's really where I wanted to close. Hopefully I've left enough time for questions.
Thank you so much. And Amy, is there anything that you wanted to add to Nim's commentary?
Nothing in advance in addition to that. Thank you.
Lovely, thank you very much. So, Sanj.
Thanks. Really helpful presentation. Just a couple of questions. Does it help us in terms of faster turnaround on some of the nationally verified data, e.g. on productivity, as a result of being part of this system? Does it facilitate a faster sort of turnaround in terms of getting that data back? You know, just based on some of the impacts, how extensive was the trial? You mentioned Northampton, I think, in Chelsea and Westminster. I'm trying to get an idea of how statistically valid that is, or whether there are other factors beyond the platform itself. And then lastly, are there investments an ICB need to make over and above what is potentially being offered for early adopters at this stage? You know, it's not always just the FDB system. There's other things that you need to get in place in order to make this work that fall on the ICB. Is that the case in this instance, or is it at least for the early adopters an all-inclusive package? Thank you.
Okay, brilliant. Thank you. So the question around the productivity data sort of turnaround, I think I'd need to sort of check the specific data sources that you're referring to in terms of productivity. But as a broad statement about how quickly can National be able to turn it around locally, and then locally trusts who have adopted, and trusts and ICBs who have adopted tenant turning it around back into NHSE, that is one of the sort of core use cases. So the whole sort of be all and end all of the FDP, when trusts, ICBs and National all adopt a tenant, is that should be automated. So it should remove any manual burden that exists currently around use cases that you've just, similar to the ones that you described. In terms of the specific data source you were referring to, I would have to sort of double check where that is in terms of the development with regards to right now the program has built national tenant and they are sort of moving data flows into it. So it's probably a work in progress, but I'd have to take back the specific data sources in question and come back to you with a more informed answer, if that's okay. The second point about the statistical significance of the pilots that were done. So the pilots were done actually across 33, I believe, NHS trusts. So even though I've mentioned a few names, that was like the very, very, very early stage. So Chelsea Westminster was literally the first trust to incubate a product in the FDP. It wasn't called the FDP at that point. It was something called the Integrated Elective Care Coordination Program, or IECCP for short. That then spun into the FDP. So that was a precursor proof of concept to generate the business case that then turned into the federated data platform. So it was a fairly robust business case that went to HMT to get signed off. So
it's very helpful.
I'm confident about the statistical significance of the proof of concept that was done earlier. And then the third question about ICB investment, any further investment needed. My genuine view, and this is just me speaking really honestly and candidly, this is the best support package that's going to be available, because they are really trying to drive that local adoption. Like I said, it covers a fair amount of support that you'd need to derive the benefit. And the investment that's asked for at trust or ICB level is not in financial terms. It's more like the discretionary capacity of colleagues in their BAU role. We've quantified it to be 3 FTE per sort of local deployment, but that's almost a thin slice of many people who'd be involved in the adoption. So that's operational staff, business intelligence staff, executive colleagues, etc., etc. So that's typical of any sort of, I guess, change intervention. I think you mentioned about the sort of extracting whether the FDP was the sole cause of the. Sorry,
Can you
go
hear
back.
me?
Yes, yes.
Sorry, can I just pause you because I've got a few questions from colleagues who would like to ask you as well. Can I just pause on that for a second?
Absolutely. Yeah,
Neil?
absolutely.
Hi, Amy. I'm Neil Walden. I'm non-exec on the IC board. It may be that Kelvin may want to come in on this question, but looking at this, it looks a useful, but in some ways, at this early stage, limited in its scope in terms of what it's doing in terms of federated data across the whole system. As an ICB, we've explored the use of population health management programs that are very much focused on patient trajectories, patients' journeys across the system. Does signing up to a federated data platform, either now or in the future, negate the independent use of other data management platforms for an ICB?
Should I take that question then?
Yeah, please.
Yeah, I think the short answer is no. Well, when you said platform, it doesn't negate the ability to use other products. But in terms of the platform element, I'd have to specifically understand what you meant by a population health management platform, because the idea of the federated data platform is it is what sits on top of your source data, so your EPR. You'll have workforce data, you'll have a number of sort of data sources. The federated data platform sits on top of it. The population health management solutions, including the ones that NHS England are building, and I'm sure others from other vendors, will sit on top of that platform to ingest the relevant sort of population health data to obviously derive the insight or whatever the use case might be. I don't know if that answers the question, but it depends on what you meant by platform.
Okay. So can I just thank you, Nim, for that answer. If you can answer that in a second, but can I ask you just to start to think about wrapping this up now?
Okay.
No, Nim, don't go away.
Okay.
The question that I'd like you to deal with when you're answering the question for Neil there is, whose decision is it to do this? Is this just for the ICB to be informed? Is this a collective decision? Is this a trust decision? I don't know. So there's that I'd like you to answer. And what captured my imagination when I first heard about this was a slide that I saw, Nim, that actually talked about 6% productivity as a result of introducing this. Now, that won't shock anyone. That sort of caught my imagination. So 6% of what? 6% of £2.50 in the corner? Or 6% of 1.4 billion? What I'm trying to get at is, can you give us some scale as to what are the user benefits and what are the financial benefits that flow from this?
So kind of addressing Neil's point and setting the FDP into a wider context. One of the things that's really interesting about the initiative is we were thinking about doing something along these lines anyway, and we would have had to have invested in that because the actual underlying infrastructure approach, data model approach, and then the benefits that sit on top of that are, I'd describe that as kind of the modern way of handling data. We're doing some good things at the moment where actually we're doing good things, but they're sitting on top of obsolete infrastructure. So the support offering here, I think, is attractive to us because it's taking us in a direction that we were going anyway, and there's an opportunity for support which needs to be looked at more carefully. And absolutely, we then need to build in that strategy to make sure that we retain those local benefits whilst being part of a bigger programme. And then I think around the kind of productivity question, I think it's implementing a solution like this that starts to give us the insights we've been talking about to then plan out what the overall impact in productivity is likely to be. The examples that are given are quite specific examples. So it might be 6% in terms of, say, theatre utilisation, which is one small, it's not small activity, but it's one activity within the acute setting. Steve exactly will come in to say there's a much bigger picture around our services in the round. And then the last point around the decision-making is it does have to be a collective decision-making process because there's an opportunity for the acute trust as an opportunity for us as an ICB. I think we need to want to do in both. I think if we tried to just do it in one or the other, then we absolutely will be back in the situation where we're not delivering.
That's what I'm asking. Yeah, thank you for pointing that out. Steve?
Yeah, I saw the 6.6% figure in terms of improved theatre utilisation, and that stood out for me. We're round about top decile performance in the country currently. If we achieved that, we would be, by some stretch, the very best in the country. It would have an extraordinary impact on productivity, which probably makes me want to test the benchmark trusts that you compared against, and is that a viable level of achievement? So I don't think we do that there, but I think, like you, John, I was absolutely looking at the productivity aspects. It seems to me, and I might be misinterpreting it, that the entirety of this programme is focused on an acute hospital setting, therefore incredibly useful to an acute hospital. I'm not entirely clear on the ICB nature of the discussion, aside from oversight and challenge. This looks like this could be really valuable from a system perspective if it encompassed community, trust, mental health, and kind of wider community data. And if that's the intent, that feels like it's an ICB discussion. If not, I'd be wanting from an RCHT perspective with Kelvin and Nim and colleagues to look at what opportunities this would give us to drive further improvements. But I might be misunderstanding the kind of content.
I that question when we had a quick pre-discussion. The programme at the moment has focused initially on acutes, and obviously, as Nim was saying, 30 plus acutes have done the pilot. We would be in the vanguard of ICBs if we adopt it as an ICB. And I already made a pitch in terms of our community mental health trust. We would want to bring in. I think the opportunity for the programme is that Cornwall is already a very well joined up system, and so we've got something to bring in terms of the way that we work for the programme.
I'll come back to that if I may. Did you want to add something a second?
Yeah, only just part of the, you were sort of quoting stats there, Steve. I think my interest would be obviously validating 6% of what, but also it's the relative position in it, to, which we're always being compared with 1920. So if we're currently at 18% or minus 19%, aiming for 12.9%, which is the last number we had for 5-6, is it a contribution to improving it further or not? That's the question, I guess, that I don't think.
Without sinking down into the detail of the specific numbers, I think what it does give us is a single version of the truth for Cornwall and the Isles of Scilly. And if we do start to get CFT data flowing through it, it gives us a whole system position. But even without it, because we need to see a change in our CHT's utilisation in order to be able to demonstrate that our CFT and community and general practice services are working, I think for something that gives us a control, like a design freeze every time we get it, we've got a snapshot that gives us, for our system, quite a lot of information. And I think it stops us arguing with each other. Is it validated? Is it not validated? Which point did it come from? Which point of delivery is it looking at? It just gives us something that we can be bound together by.
Health hat on for a minute. Yep. So it's very frustrating to see how much investment continues, and I apologise to my colleagues for this, but continues to go into acute focused tools. And if you think about the challenges that both community and mental health trusts have had historically and traditionally on data support, and a lack of business intelligence, that we as a board have had to invest in that capability ourselves to ensure that actually we are seen to be able to demonstrate things like grip and control and use data to improve care. So if we were to progress with this, I'd actually want us to have some parity and to say what elements of this actually could apply to us, given that we're not working in silos anymore, are we? We're working together. Is there an opportunity to put our community waiting lists through the RTT treatment? is, you know, could we do it? Could we be at the vanguard of actually doing a little bit of what Chelsea and Westminster did with our community data? So I'm not asking for the whole moon on a stick, but I would actually like to trial something here that hasn't been trialled elsewhere to the benefit of our people.
Okay.
So I just want to reflect why acute trusts are the constant focus of national attention. And that's because if I add up our spend on acute services in RCHT and UHP in this county without specialised services, it's 50-60% of our spend. And we also know it's an area where we're looking for the greatest transformation over the shortest time period to enable new pathways to come together. So I accept your point, and I think you're right. We should be holding ourselves to account for making sure those pathways are reflected, but we shouldn't lose the point that we should all be very interested, not in telling Steve how to run his hospital or Mark Hackett how to run his, but that the money we spend gets the maximum population benefit. And that, I think, is what this gives us the opportunity to do.
Okay, so
Kelvin, for me, responding to Steve and to Debbie and to Kate in some ways on that, he says, if what I've heard, not often you get a free lunch. So if a national team have actually, well, you might today, by the way, colleagues over here, all right, but it's not often you get a lunch. And if what we're hearing here is early adopters get the benefits of this, I think, does anybody disagree that we would want to be an early adopter in this process? No? So I think we could note and support, we want to be an early adopter in that. I think there's something then about doing, which is why I asked the question, who decides? I think really this would be a pivotal moment in terms of joining us up. And if this was the ICB and RCHT and CFT, if that was the right thing to do, so that we had one version of truth and all the things that you've talked to me about in terms of the benefits that flow from that, that's something that we would collectively get to. We're not deciding today, all right? But just if that's a benefit, then there's some part of me that then is also trying to triangulate this with your point earlier on about prepping for September for 25, 26, because if there are collective benefits of productivity that come from this, I'm sure, Debbie, you'd want to know for the bits that are in your section that are relevant to this, but Steve, this must be right on your front doorstep in terms of how does this take, because maybe Chelsea is a lot further back than we were too, so there was a lot more benefit that they could get out of it. All right, so recognising 6% is a number that worked for there. It might not be for us, but if there is productivity benefit, I'm sure as part of the September conversations that take place over the autumn and spring, that would be beneficial to bring out. So, Tan?
Mine's a yes and to all of that, John. I suppose what we would like to push back perhaps to the national picture is, yeah, we want to do this, but we also want to see people's journeys and how that aligns with place. So it's just putting some markers in there for the future.
So, Kevin, what would you like now from this final session that aggregates your first session and this, that we can conclude with Nim and Amy?
Yeah, so I think the consistent theme across both sessions, I think, has been one of anything board colleagues can do, and the questions you asked were fantastic, I think, in terms of challenging us around getting kind of the citizens' voice into everything that we're doing, both actually in the short term and the long term development of the strategy. So I think actually when you're asking questions of any initiative, whether it's me presenting or a colleague, asking those questions around, so where is the citizen design in this, and is there a digital element that combines those two, really helps, I think, reinforce the message of as an enabler we're working together, not in separate silos. And I think it's a similar picture with the FDP around everybody recognising that as a system, we're all contributing to it. We've got separated solutions at the moment. There will be a change effort in moving, so I'm not going to shy away from a solution like this. If we were a greenfield site, it would in some ways be easier than if we didn't have to move off of some of our existing capabilities. So I think we need to take away now to work with the FDP team and local colleagues to actually come up with a proposal that sets that context, how we would go about it, and then obviously the benefits in a business case terms.
So I would like to thank you, Kelvin, for all the preparation work and all the work you're doing on this. Fantastic, as always. I'd like to thank Nim and Amy. a tremendous presentation in a short window of time. You've got a lot across there, and I think you've really energised us and excited us. And I think you can see that we're committed to doing this, Nim and Amy.
Yeah, brilliant to hear. And just to close, John, I think the term free lunch, whilst you said it candidly, I would agree. Like this is sort of a no regrets decision for me. If I was an ICB chief exec chair or a trust chief exec chair making a final decision on this is get on the bus, because the quicker you are, the more you're going to get out. So hopefully that's okay to say whilst
Can we do that online, by the way? Anyway, all joking apart, thank you very much.
Thanks,
Have a very
Nim.
good day. Thank you to you both. Thank you.
Bye.
Excellent. Well done to you and to your teams.
Bye.
Thank you. Okay, so we're nearly there, colleagues. We just have the forward plan. So can I just bring you to the forward plan? For those of you who forget how this works, we try and have the forward plan here. And then tonight I'll have a conversation with Molly about anything that's come out of today. I'll then meet with Molly and Kate on probably Monday or Tuesday next week, once you and the executive team have had a conversation on Monday about the agenda. So anyone wants to plug into the agendas post today, that's the time frame to do it, so we get ahead of the curve. I just draw your attention to on this document for July. If there's anything there that you feel shouldn't be there or added, I personally just want to draw your attention to the equity and EDI paper for when we actually get later on to the Roger Klein session, what comes out of that, and then how we bring something back in that meeting, which needs to go through your workforce committee.
It needs a lead assigned to it as well, John.
I didn't hear you, sorry.
It needs a lead assigned to it as well on the forward plan.
Yeah, that's a good call. I'll talk to Kate about that afterwards. Anything that Tracy first?
Yeah, just a question for Kelvin, who's disappeared,
Yeah.
which is we were receiving the draft strategy here today. So is that due to come back next month in its final form? Because I can see some alignment with it coming with the infrastructure plan in terms of estates as well.
What I was going to suggest was whether there'd be a value to Kelvin, who's unfortunately stepped out, that we actually have as part of our, not August development day, but we have a quarterly development day, everyone, if you recall. I'm just wondering whether in the November window we ought to spend the vast majority of our time on our digital kind of thing, because it, and then think about how the clinical teams engage with that and that kind of thing. Would that work? So let's think about on a development day how we do that. Is that all right?
Yeah.
Debbie?
Yeah, so because the LD deep dive was delayed until last month, the children and young people's one's coming really quick on the heels, and I think we've been in touch with Molly to say, can we recalibrate the phasing of the deep dives?
Fine.
So Molly's already had contact.
So if Molly's got that, can she pick that up with you? And then the two of you and with Tracy agree what you would like as an order from the executive group. Maybe then we're happy to go with that. Neil?
This is earlier mentioning of Amanda Pritchard's primary care importance. I think we've been waiting a while for
Yep.
That will be on the July agenda.
It's on there.
Yeah, I know.
Yeah, oh, well,
I was wanting to ask, can we make sure it does?
endorsing that. So can I just make a point then, Tan, through your committee, you need to make sure that the journey of papers through to our board has gone through that scrutiny before it comes in, please.
Can I make a plea, as we've now got the new place directors in. So when we're talking about transforming primary care, yes, there is a pan-Cornwall view, but there is almost very much a place-based view that is part of the PCNs and integrated neighbourhood team. So I think it would be remiss of us not to ask people to come to talk about all of that, not just primary care, but primary care in the context of, you know, wide-scale transformation.
No, by a bit of accident, what Kate and I have spoken about is at the July board meeting, over lunch between part 1 and part 2, we're going to bring all the new deputies that were reporting to the new directors here, of which you've got a key team that are place-based and that kind of thing. and we'll extend lunch slightly, not because of lunch, but to actually have an informal session about introducing who they are, chatting to them about that, and structuring their engagement so they don't feel removed from our board. They actually feel engaged with it.
Yeah, absolutely.
All right. So if you could make sure they have that in their diaries. I've asked Caroline to make sure your colleagues have that in their diaries, but
perfect.
particularly that cohort would be lovely. Colleagues, is there anything else? We have no questions at the start from the public? Is there anything from the public that would like to ask now? No, thank you very much. In which case, I'm going to close the meeting for lunch. And as we're running slightly late, is it acceptable to come back at 1:15, which is 25 minutes? Yeah. Is that all right with everyone? Yeah. See you at 1:15. Thank you very much.
Thank you.